lipoproteins are synthesized in two locations. So in the intestine and then also by the liver. So perhaps we double click on that and we start to think about what are the different types of lipoproteins that the body is producing.
Yes. And there's always a caveat in lipidology. So yes, the lipoproteins that are so crucial that are synthesized in the intestine or the liver are one class of lipoproteins. But there is another class of lipoproteins that are not made in liver cells, are not made in intestinal cells. They self-create themselves in the plasma. And those will be our high-density lipoproteins, our HDLs. And what this makes, how you distinguish them from all the other lipoproteins, chylomicrons coming out of the intestine, very low density lipoproteins coming out of the liver, the byproduct of a VLDL, which would be an intermediate density lipoprotein, or our friend Mr. LDL, low density lipoprotein, which can be directly made and synthesized out of the liver, or could be the byproduct of VLDL and IDL catabolism. As they lose their lipids, they get smaller, 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 and you go from very low density to intermediate to low density. So, but the VLDLs, IDLs, LDLs, and the chylomicrons, we differentiate them from the HDL particles because of the protein that enwraps these particles, giving structure and stability. Chylos, VLDLs, IDLs, and LDLs have one major monster integrity structural protein enwrapping them, and it's called apolipoprotein B, APO for B for short. And thank goodness there is just one ApoB per ApoB particle, so that lends itself to being a fantastic laboratory measurement. If we just measure ApoB concentration in the blood, we are actually counting all of the ApoB particles. For short, we call them the beta lipoproteins. So it's a big family, chylos, VLDLs, IDLs, and LDLs. Whereas the ApoA1 family, ApoA1 is the structural protein of our HDL particles. Both the liver and intestine manufacture ApoA1, the protein, but they secrete it. And then you have free ApoA1 floating. It's a protein. It can circulate in the plasma, but it virtually instantly attaches to cells that are willing to give up cholesterol. And the little ApoA1 starts what we call lipidating with cholesterol molecules. And before you know it, you have more mature big HDL particles self-constructed in the liver and the plasma, whereas the ApoB particles are made in those two tissues and secreted.
You mentioned a few things there I want to unpack. So we eat a meal and that contains some fats. And let's say there's some dietary cholesterol in there as well. That comes in down the esophagus, it goes into the stomach, it comes into the small intestine. And our body says, well, let's absorb some of those fats. That's an energy store, that's great. And it may pull in some of that dietary cholesterol, I believe, along with some other cholesterol that's in the intestine that could have come from the liver. I'll get you to unpack this, but I'm just going to try and summarize. In the intestine there, the fats and the cholesterol get packaged into these lipoproteins at that stage called chylomicrons.
When you have whatever collection of lipids in your intestine because you swallowed them, and there could be cholesterol, there's almost certainly fatty acids. You may have swallowed them as triglycerides, but the intestine hydrolyzes them to fatty acids. So once these lipids are coming out of your stomach, the duodenum is the first part of the small intestine, but there's a duct that empties into the duodenum, and the pancreatic duct secretes all these enzymes that'll dissolve the various lipids. Even the cholesterol we eat, most of it is an esterified form of cholesterol ester, which is too big to be absorbed. It has to be deesterified by pancreatic enzymes. So once those lipases from the pancreas, and we have a whole bunch of absorbable lipids, fatty acids, cholesterol, phospholipids. There may be some phytosterols because you ate plants. They have to be brought to what we call the brush border of the small intestine. That's a bunch of villi that stick out. So you can imagine the surface area that gives. But how do the lipids find their way to those microvilli of the brush border? There's actually an intestinal lipid transportation vehicle. And thank God Our liver happily secreted bile acids down the bile duct into the intestine, comes out in the duodenum, and bile acids round up the lipids. And when you have bile acids surrounding fatty acids, cholesterol, phospholipids, phytosterols, they're called biliary micelles. It's basically an intestinal lipoprotein, but there's no protein involved with it because the protein would be catabolized in the intestine to amino acids. So the biliary micelles, which are lipid-carrying packages, they go into the brush border of the small intestine. And on that surface area, we have a bunch of receptors, distinct receptors. There are receptors that recognize the fatty acids and pull fat. They're called fatty acid transport proteins. They pull fatty acids into the enterocyte, which is the intestinal cell. But there are also sterol recognizing receptors. The major one is called the Niemann-Pick C1-like one, NPC1L1. It recognizes any sterols that are in that biliary micelle, and it pulls them into your intestine. So step one of absorption is, hey, fatty acids found their way into the enterocytes, cholesterol, maybe some phytosterols got in here, phospholipids, partially hydrolyzed, they got in too. So now it's the job of the intestine to take all these primitive organic lipid molecules. The fatty acids get resynthesized into triglycerides. Cholesterol, most of it gets reesterified to cholesterol ester. The phospholipids pick up one other fatty acid. So a phospholipid with one fatty acid called a lysophospholipid, but most phospholipids need two fatty acid legs. So it acquires one. Now all of a sudden the enterocyte has a pool of phospholipids, triglycerides, and cholesterol ester. Some of the cholesterol does not get esterified. That's called free or unesterified cholesterol. So what does the intestine do with this new glob of lipids it's got? It doesn't want it. You can't keep the lipids because too much lipids cause injury to cells. So then they do what you hinted at. The enterocyte says, oh, here's the ApoB protein I made. I'm going to take all those lipids, stick them on ApoB, and I just made a chylomicron. And the intestine releases the chylomicron not into the bloodstream, but into our lymphatic system. The lymphatic circulatory system, nobody thinks about it, but it's a major transporter of so many things. So the chylomicrons, which are gigantic, by far our biggest lipoprotein, go up the lymphatic circulation, which ultimately enters into the blood vessels in the neck, the thoracic duct it's called. And then all of a sudden the big chylomicrons are in the bloodstream. Then the chylomicron can go wherever it wants to go to deliver its lipid load. And by far the primary lipid load of the chylomicron is triglycerides, because we just ate all those fats. Now the chylomicron knows exactly who wants fats for energy. And it's people like you who use your muscles. Muscles need energy. So the first pit stop of the chylomicron is it goes to muscular beds. Now, if you want your heart to keep pumping, that's a muscular bed too. So chylomicrons are a major supplier of energy in the form of triglycerides to skeletal muscles, cardiac muscle, and any other muscle in our body. Smooth muscle cells need energy too. And how does the chylomicron know to stop, like in your muscular beds or in your myocardial beds? Easy, because those tissues, when they need energy, triglycerides, they express triglyceride dissolving enzymes. The major one is called lipoprotein lipase. So here comes this big fat chylomicron. It pulls into your deltoid muscle. You're going to work out. The deltoid muscle needs energy. It will express copious amounts of lipoprotein lipase. There's a protein on the chylomicron that is a ligand for lipoprotein lipase. And the triglycerides get hydrolyzed. That means the fatty acids break away from their glycerol backbone. The chylomicron releases those fatty acids, and the deltoid muscle says, thank you. And they are just pulled right into the deltoid muscle or any other muscle in your body, and they're happy. Now they can start beta oxidation of that fatty acid and create ATP. But you can imagine this. If a chylomicron is supplying copious amounts of triglycerides, and it's by far the biggest triglyceride carrier, sooner or later it's going to lose its triglycerides. And what will happen to a big balloon full of triglycerides when you start like taking the air out of the balloon? It shrinks. The balloon would shrivel, but the chylomicron starts to crumble. Its diameter decreases. And when it does, what has to be released? Whatever's on the surface of the chylomicron, phospholipids. So phospholipids break off from the chylomicrons as they're undergoing what we call lipolysis, hydrolyzing their triglycerides, becoming a smaller chylomicron. And because it's smaller, we call it a remnant chylomicron. What did the muscle not take out of the chylomicron? Cholesterol. Muscle, if it needs cholesterol, it'll de novo make it through synthesis. It doesn't need a delivery of cholesterol. So the chylomicron loses trigs, loses surface phospholipids, but it loses no cholesterol. And that's why the cholesterol remnants are basically cholesterol-rich chylomicron particles. They've lost much of their triglycerides. Now, the good news is when the particle shrinks, there's another protein on its surface called ApoE, several copies of it. So, and once as the particle shrink, ApoE assumes sort of a different conformation. ApoE happens to be a major ligand for the two receptors in the liver that clear ApoB particles. It's called the LDL receptor-related protein, LRP, which ApoE is what it recognizes, and the LDL receptor recognizes ApoE. So chylomicrons, their half-life is in minutes. Their plasma residence time is 2 hours because our body is just so efficient at hydrolyzing the energy that the tissues need. It disappears. Once it shrinks, ApoE pops up, boom, the liver grabs it and it's cleared. That's why it has a very short plasma residence, but it successfully did what it was supposed to do, bring energy to the muscles. So it's just a fascinating story on how quickly it comes and goes. And this is why if you get a blood test and you want to measure chylomicrons, it has to be a postprandial blood test. Because if you're fasting, the chylomicrons are gone in a couple of hours. So if you fasted for 12 hours, unless you have a bizarre lipid disorder, there will be no chylomicrons in your blood. So when you do a fasting triglyceride, and of course, there will be triglycerides in your fasting specimen. They're not from chylomicrons. So I don't have to give you the whole story again, but what is a VLDL produced by the liver? It's basically a smaller chylomicron, but it's a triglyceride phospholipid delivering vehicle. So the VLDL goes to those same damn muscles after the liver secretes it. It undergoes the same hydrolysis with the same enzyme, and the VLDLs deliver triglycerides. They deliver no cholesterol, and once they shrink, they either become an IDL or the liver rapidly clears the VLDL remnants. So the half-life of a VLDL is a couple of hours. Its plasma residence time is 6 hours, 8 hours. So that's the delivery of energy. But a wonderful part of that story is when the VLDLs and the chylomicrons are shrinking, undergoing lipolysis, what are they shedding? Their surface phospholipids. And where do they go? They either can jump into next to the contiguous cell that the particle is butted against, because cells need phospholipids. But most of those phospholipids are grabbed by another protein that floats in our blood. It's a phospholipid scavenger protein called phospholipid transfer protein. So what does this protein that now gathers several molecules of phospholipids do with them? Now we're going to introduce our little baby friends, HDL particles. I told you the liver, intestine secreted ApoA1. It's going to cells because it accepts cholesterol. It's being effluxed out of any cell that doesn't want cholesterol. But if ApoA1 has now gathering cholesterol molecules, how can it mature into a big HDL particle? What does it need on its surface? Phospholipids. So the phospholipids that were shed by chylos and VLDLs, grabbed by phospholipid transfer protein, are raced to the maturing little baby HDL, which allows the HDL to grow and become a big, mature, very cholesterol-laden HDL particle. What you should be gathering by this is, wow, our lipoproteins, yes, they're a cool lipid transportation system, but they work hand in hand to help each other. build up, empty, and so they're all related. You can't change one without changing the other, and that sometimes will show up in the metrics we measure. So that's the delivery of the triglycerides. The cholesterol that was in any VLDL particles or kilos, once they're depleted of their triglycerides, is rapidly returned to the liver. Their VLDLs and chylomicrons do not deliver cholesterol molecules to any cell. But I did say some of the VLDLs, not kilos, VLDLs, when they lose trigs before the liver or as the liver is clearing them, some of them don't get cleared. They become intermediate density lipoproteins. It's basically a smaller VLDL remnant. And there's a little bit of trigs in them. Still, this is a lot of cholesterol, the same amount that was in the VLDL. And the IDL's half-life is like an hour. Doesn't linger at all. Why? Because the LDL receptor in the liver is they grab IDLs because the ligand for an LDL receptor is the ApoB that's on the IDL and the ApoE, which is still on an IDL. So they have no plasma residence time. As an IDL is being cleared at the liver has a surface enzyme called hepatic lipase. And it grabs some of those IDLs that the receptors try and internalize, but it causes further lipolysis. So the IDL shrinks. It's not internalized. It becomes what? A smaller IDL, a low-density lipoprotein. Now, an LDL is devoid of ApoE. It's only got this ApoB on it. So LDL receptors prefer to clear particles with ApoE and ApoB on it. So all of a sudden, LDL receptors are third in line for particles that the liver wants to clear. That means LDL particles have an immensely longer plasma residence time than do kilos for sure, VLDLs, IDLs. They're all a matter of hours. The LDL hangs around from 2 to 3 to 4 to 5 days. Wow. Now, that's not a mistake. Evolution wanted an LDL to hang around for that long. So why? And most people will say, oh, Tom, because the LDL has very little triglycerides. It's mostly carrying cholesterol. It's going to go deliver cholesterol. Almost never. Maybe in a pinch if the adrenal gland is overworking because you're in septic shock and you got to make 2 tons of cortisone today, the adrenal cortex will upregulate LDL receptors and the LDL can supply it. Gonads virtually never express LDL receptors to clear LDL particles to get cholesterol because gonads synthesize a ton of cholesterol, or if they really needed extra cholesterol, they would extract it from not LDL but HDL particles. By the way, and this is why you could have an LDL cholesterol of 10 and have no gonadal dysfunction or no adrenal cortical dysfunction, because LDL doesn't supply those organs with their cholesterol. So keep that in mind. So here, why do LDLs hang around for so long? There's got to be a purpose, because you know if LDL particles exceed a certain threshold, bingo, right into your artery wall, creating that disease, atherosclerosis, that we don't want. So here's why an LDL hangs around, hopefully in physiologic concentrations. I've hinted that ApoA1 extracts cholesterol from any cells that is trying to get rid of unneeded cholesterol and forming bigger and bigger and bigger HDL particles. Now, everybody thinks, oh, and then the HDL just scoots it back to the liver. That's reverse cholesterol transport. Nope. Could be. And HDL can do that if it so fits, but then the HDL might be destroyed at the liver. It takes time to go to the liver. Would there be a quicker way for an HDL to get its cholesterol back to the liver? Yep. Evolution gave us a lipid transfer protein called CETP, cholesterol ester transfer protein. It really should be called CETTP, cholesterol ester triglyceride transfer protein, because it's mostly that's a protein that's carried on HDLs. But if an HDL full of cholesterol, or an HDL that it has cholesterol bumps into an LDL, that CETP it's almost like it gets an erection, the HDL particle. CETP sticks up and it penetrates the LDL particle. So all of a sudden, the HDLs and LDLs are going to transfer their internal fluids. They're having sex with one another. So one molecule of cholesterol goes from the from the HDL to the LDL. But in return, the LDL will send a molecule of triglyceride to the HDL. So what would happen if that happens a bazillion times every minute? HDLs, which pulled cholesterol out of cells, which kept those cells healthy, prevented cholesterol toxicity, said, hey, LDL, do me a favor, take my cholesterol, you bring it back to the liver for me. And when you deplete that HDL of cholesterol, it becomes smaller, it can go acquire more cholesterol. But if the HDL acquired triglycerides from the LDL or even the VLDL in exchange, once that HDL gets a little extra triglycerides, it is subject to triglyceride hydrolysis from hepatic lipase, and that's how you create small HDLs. But good, they're the ones that can go and fill up back at the cells. Now, once the LDL has accepted cholesterol from an HDL, the LDL goes to the liver. Here are those LDL receptors. Bingo, grab the ApoB on the LDL particles and pull it into the liver. If LDLs take cholesterol from an HDL and they return it to the liver, what is the function of an LDL? Reverse cholesterol transport. That's why we evolved LDL particles. LDLs rarely deliver cholesterol to any peripheral tissues, and they can't cross the blood-brain barrier, so they sure as hell do not supply the brain with any cholesterol that the brain may need. I saw a tweet from you today that discussed that, and you were spot on. So here, reverse cholesterol transport, we all were taught, oh, it's just HDLs bringing cholesterol back to the liver then can get rid of it. Yes, HDLs can do that. That would be called direct reverse cholesterol transport. But if an HDL gives its cholesterol to an LDL and it returns it to the liver, that has been labeled as indirect reverse cholesterol transport. Total reverse cholesterol transport is direct plus indirect. And this is why looking at a serum HDL cholesterol provides zero insight as to this complicated pathway called reverse cholesterol transport. You could have an HDL cholesterol of 5 and have phenomenal reverse cholesterol transport. You could have an HDL cholesterol of 160, have no reverse cholesterol transport. So we can't, doctors have to stop telling patients, oh, thank God your HDL cholesterol is high, you have great reverse cholesterol transport. Why, if reverse cholesterol transport is an HDL getting rid of cholesterol, why the hell would it be high? Doesn't even make sense to say that. So I'm going to pump back to you because I wander and I've tried to give you some of the complexities of this lipid transportation system.
No, that's incredible. I'm going to try and summarize a few things and you can tell me how I'm going, where I'm going wrong. Okay, so what I'm going to try and do is talk to the origin of these different lipoproteins, where they're coming from, summarize some of that. So we have the enterocytes, which are, I guess we can think about, you have this the kind of small intestine, I guess we could say the lumen, where the food is. The enterocytes sort of separate that from the lymphatic system. And the fats and the cholesterol that we eat, as well as any cholesterol that comes back into the intestine from the liver, can be sort of packaged up into these chylomicron lipoproteins that occurs in the enterocytes and will be affected by these receptors. Some of these receptors, like the Niemann-Pick C1, N1, or I know you've spoken about G5, G8. We can come back to that later.
Yeah,
but
I didn't mention that, but that's part of the story.
Right. So there, some of that might explain why people sort of respond differently to, say, dietary cholesterol, for example. We could come back to that. But the point is that this is where the chylomicrons sort of their origin and where they're synthesized, and then they enter the lymphatic system, they come into circulation, they're providing a great source of energy particularly for our muscle cells, and they're also not hanging around a very long time, a very short residence time. And they dump off some triglycerides, they become smaller, they become these chylomicron remnants, and then they go back to the liver. and the liver can kind of recycle those or do what it needs to do with them. Then the liver, the other or the second sort of primary place of synthesis of these lipoproteins is occurring in the liver, and the liver can produce, from what I heard, I previously thought it was just VLDLs, but in reading your work, I now understand it can actually produce LDLs as well and pump those straight out. So it produces these let's say VLDL molecules, lipoproteins, pushes them out into circulation. They're now delivering triglycerides to tissues that need them. And as they dump off triglycerides, they become smaller. They then take on a new name where they're less triglyceride rich. They become IDLs. Same thing happens again. And then they can become LDL molecules. And these LDL molecules, their primary role sounds like it's to bring cholesterol back to the liver, or in a system that's working well, they're bringing cholesterol back to the liver directly through the LDL receptor, but they're also taking cholesterol off of HDL particles. Does all of that sound right so far?
You nailed it. You just left out the little crucial part about phospholipids being shed so they can go help HDLs mature. But you nailed it, Simon.
Okay, so I understand the story up to there. And actually, it kind of makes me think about this entire system. When we think about cholesterol, given that every cell creates or can synthesize its own cholesterol, and you sort of pointed out that very rarely will tissues need cholesterol that's been produced by the liver, whether it's the adrenals or the testes, for example. So it kind of seems like the primary function of this system is to clear excess cholesterol from cells and get rid of it, as opposed to a system that is set up to take cholesterol out to cells.
Well, you're very insightful. I was told you're a smart guy. So yeah, and you've really analyzed this well. But and this is a higher level question, but why the hell was cholesterol even put in the Kylo or the VLDL, since it's not going to deliver it? Why, let it just accept cholesterol from an HDL and bring that back. So here's the reason cholesterol is in those particles. If a lipoprotein was not carrying X amount of lipids, it would be a flatbed truck. It'd be a small discoidal particle with no capacity to traffic other lipids. So cholesterol is put in there to make these, it's like partially blowing up the balloon with air, except the intestine and the liver partially fills up the Kylos or the VLDLs with cholesterol, but they leave a lot of space for triglycerides. So cholesterol is just performing sort of a stoichiometric principle of making big lipoproteins spherical. And even the HDL does start off as a protein, so it is a little flatbed truck. But that can only carry 10 or 15 molecules of cholesterol. That would solve nothing. But as the HDL acquires cholesterol and the phospholipids, it evolves from a discoid particle into a big round spherical HDL that can carry a significant amount more of cholesterol. So cholesterol is basically helping shape and create the volume in lipoproteins. It's not put in there to go be delivered somewhere. Yes, in an emergency, it could deliver it, but that emergency rarely arises, until we're dying and, cancer, they need cholesterol. So then they start being internalized or so. So that's why cholesterol is there. It's just keeping these balloons partially filled up so they can gather either more cholesterol or triglycerides.
So we can kind of put to rest this idea that if you want healthy hormone production and healthy levels of cholesterol in your cells, then you want to have a high serum blood cholesterol.
You want to have great cholesterol production within the gonads or the adrenal cortex. Thank God the brain is a cholesterol synthesizing machine, so it doesn't need any cholesterol from your blood. So that's how those organs survive and make hormones. They synthesize de novo cholesterol. And, all they need there is some acetate or citrate, which is the initial building block for cholesterol synthesis. So they have no shortage of substrate from which to build cholesterol.
In my summary, I left out one important piece of information that you spoke to, and that is the importance of that main protein that wraps around these lipoproteins. So the chylomicrons, the VLDL, the IDL, and the LDLs have this ApoB. As I understand it, they're slightly different ApoBs, but for now we'll just call it ApoB. And the HDL has ApoA.
A1. There's several types of APO. Capital A. A1 is the structural protein. But a little distinction, the beta lipoprotein family, the ApoB particles have one molecule of ApoB. HDLs contain from 1 to 4 molecules of their structural protein, apoprotein A1. And that's why you can't measure ApoA1 and get an accurate HDL particle count. But if you measure ApoB, you get a very accurate ApoB lipoprotein particle concentration, 1 peptide per particle. HDL's 1, 2, 3, or 4 peptides per particle.
You mentioned before threshold and physiological norm. So talk to us about that. When this system is working well, these LDL particles or any of these ApoB containing lipoproteins are sort of finding their way back to the liver and not ending up in the artery wall and depositing cholesterol and building up as plaque. Is that safe to say that when this system's working well and we're at a physiological norm level, that's not happening?
Perfect. And I think early in my diatribe here, I mentioned physiological concentrations. If we can keep these particles at the proper concentrations, they will perform exactly as I said they should, because all of those machinations will happen. But if the ApoB particle concentration, and remember, 1 ApoB per particle, if ApoB measurement in the blood exceeds a certain level, there are more ApoB particles circulating than the liver is clearing. And as that number goes up and up and up, the particles are obviously not being cleared by the liver. So where do they go? We have miles and miles of endothelium on our arteries. So they just pick the nearest artery and they crash it. And the ApoB particle carrying cholesterol, step 1 of atherogenesis is it passes through the endothelial lining, which is a 1-cell lining of every artery in our body. And now it's in the artery wall. And we can talk more about that later, but that's step 1. But what forces the ApoB particle to go? My joke is it's going to go where it's going to do illegal dumping. It's not going to the liver, which can get rid of the darn cholesterol safely. It's putting cholesterol in your artery wall. And the primary driving force is particle number, particle concentration. And this is why ApoB is by far the best metric that every human should get tested for when they do their cardiovascular risk assessments. Most of them get other lipid concentrations, and we'll relate the two later on. But once your ApoB goes above a certain concentration, the chances are good it's going to crash your artery wall. There are other things that influences whether it goes into the artery wall or not, but it's particle number. Very few people who have physiologic numbers of ApoB particles ever get atherogenesis or atherosclerosis. And here's the bad news. You know, our little kids don't get much atherosclerosis that we know of. Some of them do nowadays because they're eating this junk earlier and early and getting fat and insulin resistant at very young ages, which didn't happen earlier. But these ApoB particles, if you took a 5-year-old and measure his ApoB, it's 40 or 50 milligrams per deciliter. That's a physiologic. When we come out as infants, it's 20 to 30 milligrams per deciliter. And by the way, when we come out of mom as little infants, our brains are fully developed and there is virtually little circulating cholesterol in that fetus while he was in the uterus, and very little in the infant once he's born. Yet the brain keeps developing normally for several years, even though there's very little cholesterol in the ApoB particles in the brain. So there's another thing that tells you stop relating blood cholesterol to brain, whatever's going on in the brain or so. So now, as you know, as we get older and older, you get into adolescence, puberty changes the concentrations of these things. Worse in men before women. So, sooner or later, ApoB may cross the threshold from which it has the ability to start crashing your artery wall. Now, listen, if You took a 14-year-old and he's got ApoB particles, unless this kid has astronomical levels as certain genetic lipid disorders, it would take 3 decades for enough ApoB particles to pollute his artery wall with cholesterol before he might show up with a positive coronary calcium test, or even 4 decades before, like your dad, he suddenly gets chest pain and while driving or doing something else. And this goes back to how we started off this thing. God, if we would just measure ApoB early in life, we would know, whoa, let's start a better lifestyle in this kid, some exercise, not let's start 3 drugs to get his ApoB under control. We would halt atherogenesis before it's ever even beginning. But most people don't do that. Most doctors don't check that in young people. So even though atherogenesis may be occurring, and God knows through all the wars we've been through and our young heroes get shot, killed, and autopsied, so many of these 18 to 22-year-olds have significant non-clinical, meaning symptomless atherosclerosis in their arteries because ApoB has been crashing their artery walls for 18 to 22 years already. So we got to recognize it early. But this is why one of the reasons why ApoB is considered causal, because it's a marker of the particle that is carrying cholesterol, which is actually the injurious molecule to the artery wall. But no cholesterol could ever get into your artery wall unless an ApoB particle dumps it in there. So this is why ApoB has gone to center stage with the best marker. And if we exceeds whatever threshold you think is necessary, we'll start treating it and return it to those physiologic levels. And that's therapeutic lipidology in a nutshell.
So 40 to 50 milligrams per deciliter is the kind of concentration of ApoB in young humans.
Yeah, and if they could maintain
threshold?
That, they will virtually never have atherosclerosis.
What do you think is the kind of the tipping point threshold where you go from a level of these ApoB containing lipoproteins that's not causing atherogenesis to where it's beginning to?
A lot depends on what other risk factors is present in you. Now, if you had nothing else wrong with you but ApoB, it would take longer than if you were a smoker who was a diabetic, who was a hypertensive. It'd be a much shorter time before you've got atherosclerotic plaque in your arteries. So here's the levels. In general, if there are not a bunch of other risk factors of concern, we like people to be in what's called the bottom 20th percentile population cut point. In other words, if we measured ApoB on every human on the planet, let me see the people who have an ApoB concentration that is in the lower 20th percentile. And that would be 80 milligrams per deciliter. So in general, unless you do have a multitude of other factors, if you're running around with an ApoB of 80, that's probably fine. It's going to be a long time. And sooner or later, you're going to eat wrong or start smoking or secondary smoke. So you want to be lower than the 20th percentile, but that's on average. You never want to be much higher than that. You certainly don't want to be above the 80th percentile, because that's like 115, 120 milligrams per deciliter. Those are the people who most commonly get atherosclerotic heart disease. Are there people with super high ApoB who don't seem to get atherosclerosis? It's the biggest risk factor. It's causal. But yeah, there's always going to be an exception to the rule with human bodies. And what is preventing in my very small minority of people horrendous ApoB not causing atherosclerosis? Nobody knows. There must be other protective things going on. But nobody who's measuring their ApoB at age 30, 40 and says, oh, my ApoB is 140. I ain't worried about it because I'm good. I'm healthy. I can do 50 push-ups a day. I actually did a coronary calcium and there's no calcium. Well, that's good. You probably got another 5, 10 years where nothing's going to happen to you. But if you're 30 and 40 and you want to see 90, I wouldn't go 50 years with an ApoB that's sky high, because there would be zero data supporting that is safe.
I have a few more questions on some of that stuff, but I want to dive in a little bit more into the mechanism, if that's all right with you, and the term transcytosis comes up a lot in the literature, which essentially, to my knowledge, just means the movement of these ApoB containing lipoproteins from the plasma, like in the lumen of the artery in that inside of the tube, through the endothelial sort of cells or between them into the intima, which is the innermost kind of part of the artery wall. Is that sort of flux, transcytosis, movement of these ApoB containing lipoproteins into the artery wall, is that normal and happens all the time, and they go in and they sort of find their way out and nothing happens, and it becomes pathological when they don't find their way out and become retained for some reason?
Yeah. So now you're going to look at, all right, ApoB has somehow gotten through that endothelium, and I'll tell you the ways it does that. But then it's in you called it the intima. That's basically the outer connective tissue area of the arterial wall. And there are reasons why that ApoB particle, once it passes through the endothelium, it's going to get stuck there. That ApoB protein on the surface of the particle has great affinity for connective tissue molecules, glycoproteins that bind the ApoB particle, and it's like a flies on flypaper. It's stuck. Now, sometimes it's just stuck there and nothing ever happens. Who cares? Very few of them break free and can leach out again back into the plasma, perhaps a minuscule number. But once they crash there, they're stuck in the arterial wall. So as they're bound to these proteoglycans in the arterial wall, they can just be bound there forever. And like a mummy, they'll just ultimately shrink up, add to the connective tissue, and they're of no consequence. Because for atherosclerosis to develop, ApoB cholesterol-containing particle has to be ingested by a macrophage that is in the arterial wall connective tissue. How did the macrophage get in there? A monocyte left the bloodstream. It passes through the endothelium. There are receptors that pull it in, and it transforms into a macrophage in the arterial wall. A macrophage is basically a white blood cell capable of scavenging, eating things. So what makes some of the retained ApoB particles a substrate for receptors on macrophages is that they will internalize them. And now, if that macrophage keeps internalizing humongous numbers of ApoB cholesterol-carrying particles, before you know it, the macrophage becomes super cholesterol engorged. They're called foam cells because they look foamy if you look at them in a microscope. And that, if you get a macrophage that turns into a foam cell, and you get a few billion of those macrophages, that is plaque. Initially a fatty streak in the artery wall. After that, more localized collections of cholesterol. And over time, they get bigger and bigger and bigger. Most of the disease early on is in the wall of the artery. It's not obstructing the arterial wall lumen at all. Sooner or later, bad things can happen. But the million-dollar question is, after the ApoB particle goes through the endothelium, why do some get ingested by macrophages and others do not? A word first about what you said, the transendothelial passage, transcytosis of the ApoB particle. That can occur with perfectly healthy endothelial cells. You do not need an inflamed, disturbed endothelium for that particle to pass right through it. Caveoli, and there's other receptors that just pull those particles through. There is a little gap between endothelial cells, a perivascular sort of channel. They can sneak through that. These are very, very small particles, 20 micrograms, 21 millimeters, they get in. So, but they certainly can get in with greater frequency if the endothelium happens to be disturbed or inflamed. And most of the inflammation of the endothelium in atherosclerotic disease is because those macrophages I told you about, they start ingesting the particles. They start secreting all these pro-inflammatory cytokines, chemokines, which causes the endothelial dysfunction. So it's ApoB is not bad enough. It's delivering the criminal cholesterol, but then that sets off the inflammation that further destroys your endothelial cells. But there are many human conditions where the endothelial cells might be inflamed before the ApoB particle even shows up. many of our collagen diseases. You know, the list of subtle inflammatory diseases are huge. Even insulin resistance, diabetes. Yeah, you know, think of the people who have subtle elevations of C-reactive protein. Likely many of them have this. Now they have an endothelium that has less protection in keeping an ApoB particle out. So, but it doesn't have to be there. And that's why the young people develop atherosclerosis early, because they're not having all these inflammatory conditions. Particles just go right in. So who cares? If a particle gets in, you're in trouble. Whether the endothelium let it in physiologically or you got a destroyed endothelium due to other factors.
Is that also where risk factors like high blood pressure and smoking play a role? Do they feed into this, the sort of quality of the endothelium?
Even I couldn't give you a list of the pro-inflammatory conditions that probably cause endothelial dysfunction. Hypertension and its effect on nitric oxide would be one. Smoking for whatever chemicals are passing through your endothelium there, of course. Autoimmune diseases where the immune system is revved up and creating so many undesirable things. I mentioned insulin resistance, diabetes is a pro-inflammatory state. So the list is long. So try not, if you have high ApoB, try not to have any of them.
The take-home message there, though, before we move on to the next point, is that you're always going to have some movement and flux of these ApoB-containing lipoproteins from circulation into the intima. You can exacerbate that and make it worse if you have other kind of risk factors or genetic sort of conditions. But it's going to happen because I do think there is this idea out there that, well, if my endothelium is healthy, it doesn't actually matter if I have elevated levels of LDL cholesterol.
Unfortunately, that is circulating all over the internet. They go out and they do some inflammatory marker in the bloodstream and it's normal, and they declare themselves immortal. It's silly. High ApoB. Listen, FH, which is a genetic condition of too many ApoB particles that certainly causes premature atherosclerosis, is not typically associated with inflammatory markers. But those are big ApoB particles that have no trouble just passing through the endothelium because their concentration is so high. So yes, it's always a complicated story, but never ever say, yeah, ApoB high, that's bad, but if I don't have inflammation, I can't get atherosclerosis. Sooner or later, you will have inflammation because once the particle goes in and gets ingested by the macrophage, boom, now you have a pro-inflammatory state, and then the endothelium will become dysfunctional at a certain point as cholesterol gets deposited. The next step would be the particle going into the macrophage, but go ahead, finish.
Yeah, that's what I'm interested in, the next step. And I guess one of the kind of first questions I have here is, do we have any sense for the percentage of ApoB-containing lipoproteins that do undergo transcytosis, cross into the intima, and move back out versus become retained?
Well, I haven't ever seen anything that the number that leaked out. People mention it, but I've never seen quantitative studies showing that or so. I think most of them at a threshold, if they do somehow pass the endothelium, they either get caught there and they just rot away and contribute nothing to the buildup of cholesterol in macrophages. But there are some that get transformed or develop the ability that the macrophage is going to grab them and ingest them, which would create the sterol-laden foam cell. So that's the step one of, if all that happened is ApoB particles crashed your artery wall and bound to proteoglycans, I don't think we'd have atherosclerosis. How many do that? I don't have a number for you. It's considerable, but we have such high concentrations of ApoB. There's plenty that are going to make it to the macrophage and not just simply be an isolated, stranded LDL particle in your artery wall.
So if we kind of think about two ApoB-containing lipoproteins here, I'm simplifying this, and one of those let's call Peter, and the other one let's call Mary. And one of these ApoB-containing lipoproteins enters the intima, it binds to proteoglycans, but it goes no further than that. And that's what happens to this molecule called Peter. this molecule called Mary goes in, binds to the proteoglycans, and then it becomes modified and it gets taken up by macrophages. What is it that differentiates why that happens to one versus the other?
So what makes a retained ApoB particle become a substrate for the macrophage endocytosis? Something has to happen to differentiate those two particles that came in, why the one. And so it does have to be transformed. Now, for the longest time, people just said, oh, the particle goes in, it's subject to reactive oxygen species, the surface phospholipids get oxidized, and oxidized lipids are a major thing that sets off scavenger receptors in the macrophages, and the particles get intensified. And there's a lot of animal data that shows that. And there's very little human data that shows that. And this is a problem. So Peter Libby is the expert on this. And Peter Libby has been writing in the last few years, if oxidation occurs, and that's an if, because there's not a lot of human data supporting it, what else would make an LDL particle very attractive to the receptors that internalize it on a macrophage? Something has to happen to that particle. Or maybe this next step that I'm going to tell you about happens, and then oxidation happens. So there's a precursory step to oxidation if that occurs. And by the way, the reason Peter questions that is that there have been several trials of various antioxidants given to people, and none of them have reduced atherosclerotic heart disease. And some of them prescription grade probuccal antioxidants that just didn't do anything. So who knows? But here's the now believed to be the crucial first step. So what's on the surface of a retained ApoB LDL particle? Phospholipids. Now, phospholipids certainly can be oxidized, but what happens is there's, in some LDL particles, there's a rearrangement of the types of phospholipids that are on the particle. And there are certain phospholipids that are targets for the receptors on the macrophages. Sphingomyelin, ceramide, and how does the regular phospholipid content, which is mostly phosphatidylcholine on these LDL particles, suddenly change into these other phospholipids that become attractive? There are enzymes called mutases, and these mutases have the ability to change fatty acids on the phospholipids, changing one phospholipid into another. And if you create the wrong type of phospholipids, what now happens is the LDL particles, and there's many of them stuck there, they bind together. That's called aggregation. And sooner or later, you get a bunch of LDL particles because their phospholipids have this new attraction for each other. You get humongous collections of aggregated LDL, and it's the aggregated LDL that gets internalized by the macrophage. So instead of it internalizing one LDL particle, it's internalizing hundreds of aggregated LDL particles. Now, once the particles are aggregated, does some degree of oxidation occur there? Maybe, probably, who knows? But aggregation seems to be the crucial step that sets off the cascade. And there are papers written on this. I can send you nice slides, which maybe we will put into your slide notes. Remind me as we get to that stage of promulgating this message tonight. So it's aggregation of LDL particles. And if you have an aggregated clump of LDL particles, there are a hell of a lot more cholesterol molecules in that than there would be in one LDL particle. So bingo, aggregation. How much role oxidation plays after that, I like always, we need more studies, and human studies especially, not what happens in a mouse. So, because that may or may not have applicability to humans. So that's the big step, this whole new concept of aggregation of particles. And then you have the macrophage. Once that all those sterols are in the macrophage, they start creating interleukins and all the other things that then leach out into the plasma, go to the liver produces C-reactive protein, or the chemokine, cytokines, some of them that are produced. As they try to leave the artery wall, they damage the endothelial cells there, creating endothelial dysfunction. And if we don't arrest this process by forbidding ApoB particles to enter, and the only way you do that is reduce their concentration, over time, and time is critical here, years and decades, they're your father. You know, that's what happens.
The critical point being here that in order to stop that process of retention and then modification being taken up by the macrophage, turning into a foam cell, building up as fatty plaque, we have to get the concentration of these ApoB containing lipoproteins, which are mainly your VLDLs, IDLs, and LDLs that are in circulation for longer.
Well, let me stop you there. It's mostly LDLs. The VLDLs have a plasma residence time of a few hours, chylomicrons less than an hour, IDLs an hour, LDLs several days. So when you measure ApoB, 90 to 95% of your ApoB particles are LDLs. So yes, a VLDL or a chylomicron remnant can make its way into the artery wall, but it's like, 95% of the army is LDL particles that are doing the invasion. So and that's good because it's very easy to modify LDL particle concentration with various therapeutic maneuvers.
You mentioned before that there is a plethora of evidence that establishes ApoB as causal in the development of atherosclerosis. And I appreciate we're not going to step through all of that body of literature.
Please, because I'll develop a headache and have to go.
But if someone said, look, Tom, summarize that evidence that we have, where would you start?
Well, you'd start with just generalizations. You would say, here is the evidence. Epidemiologic studies, not the highest proof, but if they're 95% suggestive of a plausible reason that they're probably true. Now you have randomized controlled clinical trials where you actually control for things and you change ApoB or something during a trial, or you do a randomized study following a cohort for a long time. So, and then you get into the genetic studies. If you look at genes that are associated with atherosclerosis, and then you can do this Mendelian randomization where you can play with, high LDL cholesterol, low LDL cholesterol, high ApoB or not. Let's look at all the genes that we know cause atherosclerosis or do not, and let's see, does whatever metric you're looking at matter in these genetic, because the Mendelian studies are basically a lifelong randomized controlled trial. Nobody can putz around with anything. You got your genes, and if you got the genes that make ApoB or prevent ApoB from being cleared, you're going to go through life with high ApoB. If you don't have those genes, you're not going to have high ApoB. And we can just look at these gigantic studies and relate. And this is how some things ultimately get called causal. So you have all of these studies, and we're going to link it in your podcast notes. About 3 years ago, the European Atherosclerosis Society put out 2 gigantic papers on the causality of ApoB, where they do chart every damn study in the history of the world that does support it. So for the geeks who want to read every darn paper, now listen, I grew up through this era. I lived through all of these papers, but my 77-year-old brain doesn't remember every chapter and verse of every damn study that's ever been done. But they're there. There's not a guideline that exists now that doesn't cause ApoB causal. So the deniers think those are all experts bought off by pharma or something else, laboratories, which is ridiculous, but that's their excuse, not to argue the facts, make up stupid stuff as to why it can't be true.
Yeah, I believe you're referring to the Brian Ferentz and the Boren papers. So those, I've learned a lot from those. So we'll definitely put those into the show notes. Linking back to our earlier discussion. So I'm interested here in kind of how someone can determine whether their ApoB level or LDL cholesterol level is, if let's say it's elevated, is elevated because of genetics, or is it because of their lifestyle? And if we just start, you mentioned there's some genetic variants that can result in, I guess, an elevated level of ApoB or even a reduced level of ApoB and offer protection. And going back to where we were talking about the lipid transport system earlier, most of these genes either affecting the ability for LDL to come back into the liver or affecting the amount of cholesterol that's absorbed in the intestine?
Well, listen, I think where we're all going in this science right now is this so-called polygenic risk score that people are developing. You get an extensive genome analysis, and we certainly don't know what every gene does, but there's enough of them that we know, hey, these genes are associated with atherosclerosis or atheroprotection or just null. And if you can look at all those SNPs in a given person, you could just say, geez, you have a hell of a lot more SNPs associated with atherosclerotic risk than the guy we tested down the street who we didn't find any. So if you have an abnormal polygenic risk score, then we all ought to get that test early in life. And if you're abnormal, you have some of the genetic risk things, that's when you start then monitoring closely the causal things that nowadays we can treat. And that would start with ApoB. We'd certainly, again, tell you to stop smoking, control your hypertension. But that's the way we're going here. So, look, I'm coming more and more to the belief that every lipid disorder has an underlying genetic abnormality. Now, yes, the genes always act with the environment in which they're placed. So, depending on which genes you have, maybe if you lead a perfect lifestyle, you might be home free at the end of the day whenever death does come. But the odds are how many of us do the perfect lifestyle? So if you got a couple of genes that don't like what environment you're exposing them to, bingo, you develop it. So one of the treatments would probably be a healthy lifestyle. But I think behind every lipid disorder, if you didn't have the genes that can cause whatever you're measuring, you're home free. Maybe you can eat whatever the hell you want if you had zero of those genes and be a couch potato all your life. Maybe there'd be other morbidities related to your bones and muscles and arthritis, but you probably wouldn't get atherosclerosis. So genes, as we're now learning, are more and more. God, this is how pharma exists nowadays, because every time they identify a new gene that seems to be seriously involved, what protein does that gene make? You go in there and you inhibit it, and bingo, you got another drug that is a piece of the puzzle of wiping out atherosclerosis. And old men like me, we're taught nothing about genetics for the most part because we didn't know anything. And now, if you want to be successful in this field, that's why I'm certainly a lot closer to retirement. I'm glad, because I can't keep up with all this genetic information. So genes are everything. One day, these polygenic risk scores will be certified as being what we think they're going to be right now, but the data is pretty good now.
That reminds me of a question I have. Often I hear people suggest that, well, if you lower ApoB, you might reduce your risk of atherosclerosis, but you won't increase your lifespan. You'll just end up dying of something else. And I'm wondering, if we look at, say, I'm not sure if you've seen this, but if we look at, say, a gene mutation like a PCSK9 loss of function, so these people have really low levels of ApoB and reduced risk of atherosclerosis, and they have that lifelong, so they're born with that. Do these people show greater longevity? Do they live longer?
There are a couple of studies that have related ApoB to longevity, and we'll certainly list the papers that show that. But in general, I don't know that we have enough data on that now to say it with certainty or so. But listen, longevity there's two components to it. Yeah, we all want to live as long as we can. And the next thing is we want to live disease-free. That's health span. If I'm going to make it to 90, I want to be able to think, have a heart that beats, be able to walk without a walker. So we have to work hard at preventing the degenerative diseases. I think we can take out atherosclerosis. So maybe I don't live too much longer. I think you'd live a little bit longer, but is that a guarantee you're going to make it to 100? No, because these other diseases can pop up and then take you out. Right now, if longevity means taking out atherosclerosis, which I believe we can do, taking out cancer, taking out degenerative brain disease, and then taking out a bunch of metabolic diseases that can do us in too. And then buckle your seatbelt after that. Certainly falls is what kills the old folks like me. So early in life, we all ought to be training our muscles and skeletal system a lot better. So, But atherosclerosis, even if it doesn't, you're not going to live a day longer. You're not living in congestive heart failure. You're not living with, I can't take 3 steps because I get chest pain. You're living without TIAs. The risk of stroke is near abolished. Claudication, I don't ever have to worry. My renal failure is going to be due to atherosclerosis. I won't be developing an aneurysm in my aorta someplace. So that's kind of cool. Even if I don't live longer, none of those are morbidities you want to ever have to deal with. They'll bankrupt you. They'll certainly cause life to be a bit miserable. You'll be in and out of the hospital. So, yeah, who cares whether you live a day or longer? I suspect we will, but I know for however long you're going to be here, the morbidity of heart disease will be gone.
Yes, quality of life. I have a question around the mechanism by which ApoB is elevated, and whether, and I think I already know the answer to this question based on you describing atherogenesis and the cascade of events that occurs. But there is this idea out there that the mechanism by which ApoB is elevated somehow affects the quality or function of those particles and the ability or lack of ability of those to end up becoming retained and modified and being taken up by a macrophage. Is there a chance, for example, that ApoB containing lipoproteins are acting differently in people who have, say, familial hypercholesterolemia versus someone who has those same elevated levels of LDL cholesterol but through diet?
Yeah, there are definite studies that show if you come in with ApoB levels or LDL cholesterols that put you within the definition of familial hypercholesterolemia, and you would also, by doing a family history and other ways, make that diagnosis with certainty. But then you might start doing a genetic analysis and say, hey, your LDL cholesterol is 290. Let me find out what's wrong with your genetic system. Why is your body not getting rid of these LDL particles? So if you do a genetic analysis and you find especially a monogenic disturbance as to, no wonder you got too many ApoB particles, versus the next person who has the same very high LDL cholesterol, but your genomic screen comes up negative, the person that you've actually found the genetic mutant does have higher risk than the person who doesn't, even though the phenotype LDL cholesterol is exactly the same. But here's the thing, they're both at immense risk. It's not like, because you didn't find a genetic defect in me, I'm home free. That's nonsense. There's so many genetic defects that are yet to be discovered in everything. The monogenic defects are the worst. So now there's other thing too. If you have a bad gene defect, genes all interact with one another. Are there other genetic things going on that perhaps worsen your risk too? But there's nobody who has the ApoB level or LDL-C in the FH definition range that is ever should be told to ignore just because we can't find a gene that causes it. So yes, I'm sorry, sir, we did find a genetic defect in you. You're higher risk. But the good news is you're going to take both of those patients and using modern therapeutic modalities, restore their ApoB level to physiologic levels, and then the risk disappears, no matter what the hell the genetic cause is. And that's the good thing. You really have to know the genes that are causing it. You just have to get the ApoB under control. Sometimes knowing the genetic defect plays well with the third-party payer because the drug you're probably going to need is super expensive. And if you can show the third-party payer, look at this gene I got, they'll cover it. Whereas if you can't show a genetic abnormality, they might hold that against you. More and more just using the LDL cholesterol level and associate them with other risk factors. But yeah, so it does. But it's not like, thank God we didn't find a genetic reason for your sky-high LDL-C. You're protected. Nonsense.
Recently, I've been working with friend of the pod, Dr. Will Bolsowitz, on his new brand, 38 Terra, an evidence-based prebiotic supplement to optimize gut health. To facilitate online sales, 38 Terra uses Shopify. The major reason 38 Terra chose Shopify over other e-commerce platforms was because of Shopify's focus on customer conversion. Shopify helps you turn browsers into buyers with the internet's best converting checkout. up to 36% better compared to other leading e-commerce platforms. If you're going to spend time and money on marketing, you want to make sure you are converting the people who visit your site into loyal customers. What I also love about Shopify is how no matter how big you want to grow, Shopify gives you everything you need to take control in-house. The Shopify App Store is home to thousands of customizable apps that can easily plug into your website to help with things like upselling, selling products on social media channels like Instagram and TikTok, and much more. To boost your conversion rate and grow your business, sign up for a $1 per month trial period at shopify.com/proof. That's shopify.com/proof, all in lowercase.
Most sort of basic lipid panels, as you said, will measure total cholesterol and LDL cholesterol. Is ApoB a better measurement, a better predictor of cardiovascular disease if someone's wondering about that and whether they should go to the effort or cost of ordering that? And also, where does non-HDL kind of come into this conversation?
Yeah. So look, ApoB is the ball game. ApoB is the signature of the particle. It's carrying cholesterol. It's going to induce atherogenesis. Particle number is the primary driving force in the artery wall. So ApoB would be the best test you could absolutely do. It's rather cheap. And look, in the United States, it's available in every lab, and cash price is $10. Yeah, labs, if labs could say, oh, I want $90 for it, but most labs will give you a cash price. Third-party payers often say, no, I'm not paying for that. That's an experimental test, even though it's not an experimental test. The data is overwhelming on it. So if you can't, for whatever reason, get an ApoB, and I've gotten emails back, hey, I'm in Canada, I can't get an ApoB, and perhaps other countries in the world, maybe you have to see a specialist before you get ApoB. I don't know. But so if you're stuck with a lipid panel, the only reason you're doing a lipid panel is twofold. There's one lipid concentration that you have to know, and that's triglycerides. For two reasons. There are two types of triglyceride disorders. One where the triglycerides is well above 500. That's a rare genetic disorder. If you have that, the mission in life is lower the triglycerides to prevent pancreatitis, not heart disease. Then there's everybody else who has a triglyceride less than 500. Most typically, they're diabetics or insulin-resistant people, and most typically their trigs are in the 140, 150 range, not 400. And in those, ApoB becomes the goal of therapy. So triglycerides is important to exclude the rare hypertriglyceridemic disorders. Everything else in the lipid panel is just a poor man's guesstimate of ApoB, a poor man's surrogate of ApoB. So let's start with the total cholesterol level. Total cholesterol is the cholesterol in every lipoprotein in your plasma. LDL cholesterol plus VLDL cholesterol plus HDL cholesterol. Normally we're doing fasting, so there are no chylomicrons contributing to cholesterol levels because they disappear rapidly postprandially. So here's the trick, though. So if you get a total cholesterol level, 80% of that cholesterol is in your LDL particles. And what is an LDL? It's an ApoB particle. So total cholesterol is a super poor man's surrogate guesstimate of ApoB. At what level should you be concerned? Above 200, you've got a definite serious ApoB level. I personally think above 150, you want to run out and get an ApoB test to see where it is. So 150 to 200 should certainly suggest to a clinician or a patient you've got hyper-beta lipoproteinemia, too many ApoB particles. All right, let's jump to the test everybody talks about, LDL cholesterol. Well, remember, 90% of your ApoB particles are LDLs. So obviously, LDL cholesterol has a pretty high correlation with your ApoB level, far higher than does total cholesterol. So if I see you have an elevated LDL cholesterol, should I just assume, hey, you're an ApoB issue here and we're going to take care of it? No, because as good as it correlates, there are exceptions to the rule where the LDL cholesterol is quite low, but your ApoB is still high, or conversely, your LDL cholesterol is high, but your ApoB is normal. Those situations are said, hey, the two laboratory metrics are discordant. Normally, they agree with one another. They're concordant. So when you discover a discordance between ApoB and LDL cholesterol, trial after trial after trial has shown risk follows ApoB better than it does LDL cholesterol. So therefore, I don't want people coming up to me and telling me, oh, Tom, you're going to be so proud of me. I got a great LDL cholesterol level. Great. What's your ApoB? Oh, I don't know. Then don't even talk to me until you go get an ApoB. If your ApoB is also low, but if your LDL-C is super and your ApoB is high, you have a risk that is not identified by LDL cholesterol. I'm one of the authors on a paper in Diabetics where LDL cholesterol is 50, and about 20% of them still had high LDL particle concentrations. And yet they would be told, hey, your LDL cholesterol is 50. You have no worries whatsoever. Wrong. Discordance. All right, the final, now, well, let's get HDL cholesterol out of the picture here. That's on every lipid panel. Tragically, for years, it was called the good cholesterol. We know now that's an idiotic terminology. So what is HDL cholesterol? Well, it's the cholesterol that's in all your HDL particles. Now, HDLs are not the cholesterol, they're not the lipoproteins who crash your artery wall and dump cholesterol. There's no ApoB on them. So they're not per se part of the atherogenic milieu that causes the disease. But Framingham, when it first came out, said, geez, people with, and that's an epidemiological study in the United States, people with low HDL cholesterol seem to be rather high risk for atherosclerotic disease. And Mr. Fitt came in, and other epidemiologic studies seem to confer that yeah, LDL cholesterol is worrisome, but if your HDL cholesterol is low, it doesn't even matter if your LDL cholesterol is low. You're still at risk for heart disease. And study after study after study showed that. So much so that the lipidology world started developing all drugs that raised HDL cholesterol. Because if low HDL cholesterol is bad, if we raise it, we'll cure you. And every one of those trials has failed using a drug that raises HDL cholesterol. There was no cardiovascular outcome benefit. So now that took 30 years to happen. So it's easy for me to say now we know treating low HDL cholesterol doesn't matter. But here's what really, why low HDL cholesterol might be a risk factor, might not be. All of those early studies that came out and said low HDL cholesterol is bad news were never adjusted for apolipoprotein B because they didn't even have ApoB studies in those days. So we now know if you have low HDL cholesterol, immediately return to the lab and demand an ApoB level. And you will see by far the most common cause of low HDL cholesterol is insulin resistance and type 2 diabetes. If you have insulin resistance with a low HDL cholesterol, your ApoB is through the roof, and that's why you're going to get atherosclerotic heart disease with your insulin resistance. Statins, ADA mandates statins on everybody who's a diabetic above a certain age, and it's for that reason, to get rid of the atherogenic ApoB-containing particles. So low HDL cholesterol is a poor man's guesstimate that you probably have a high ApoB. We do know now there are people with low HDL cholesterol who do not get atherosclerotic heart disease, and we know there are people with elevated HDL cholesterol who do. So you can never make an individual decision based on HDL cholesterol. If you want to tell me, hey, that Norway's got higher HDL cholesterol than Zimbabwe, all right, there'll probably be less heart attacks in Norway than there would be in Zimbabwe, but that never translates to an individual patient where you have to zero in on the causal agent. So please, those of you who have low HDL cholesterol, measure ApoB, and if it's high, your therapeutic goal is not to raise HDL cholesterol. That doesn't work. It's to lower ApoB. Okay, the last metric, and an important one if you can't get ApoB, is you mentioned non-HDL cholesterol. Well, what the hell is that? Well, obviously, listen to what it is. Non-HDL cholesterol is the cholesterol that's not in your HDL particles, right? You don't have to be a rocket scientist to understand that word. So if cholesterol is not in an HDL particle, what type of lipoprotein particles would the cholesterol be in? There's only one other class of particles, your ApoB particles. So non-HDL cholesterol is the poor man's lingo for ApoB cholesterol. And obviously, in general, ApoB cholesterol, non-HDL cholesterol, has a high correlation with ApoB. It's actually a higher correlation than does LDL cholesterol have to ApoB. So, if you can't get ApoB, you're going to look at your LDL cholesterol. But even if your LDL cholesterol is fine, but your non-HDL cholesterol is still abnormal, you almost certainly have a high ApoB, and you need, your LDL-C might be a goal. Now you have to get your non-HDL-C to goal. What you really have to get to goal is your ApoB level. So the one problem I still have with that, where ApoB is so readily available and cheap, is yes, non-HDL-C is better than LDL-C, is better than total cholesterol, but ApoB is better than any of them. There's nice studies published that shows there's even discordance between ApoB and non-HDL cholesterol, where the non-HDL-C looks pretty good, but damn it, the ApoB is still high. That person needs more aggressive treatment. So those are your lipid measures. You do those, you throw in an Lp(a), and you're off to a pretty good start on at least ascertaining lipid and lipoprotein-mediated risk.
The sort of take-home message there is if you want to get a really good idea as to how many of these ApoB-containing lipoproteins are crashing into your artery wall and potentially causing this cascade that leads to atherosclerosis, ApoB is going to be the best test, followed by non-HDL cholesterol, followed by LDL cholesterol, followed by total cholesterol.
Yeah, but think of non-HDL cholesterol. I said, hey, it's the ApoB cholesterol. But how do we come up with that number? You take total cholesterol, the cholesterol that's in all of your particles, you subtract from it the HDL cholesterol, and you're left with the ApoB cholesterol. So it's a simple calculation that anybody who's graduated grammar school can do, and it's easy. Now, of course, somebody's going to have to teach you what are the normal levels, but you want to look at that. If you get it done in a lab, they probably have a little chart there that tells you what the risk ranges are. But I think we all got to know them all. So I don't want you to go out and just do an ApoB and not look at the rest of the lipid panel. I think all of the information is useful. If you really were cash-strapped, I'd say the really only two, once you get Lp(a), and that's done with forever, the only test you really need is triglycerides and ApoB.
Mm-hmm. Okay. So we can basically say the big three then are ApoB, Lp(a), you're going to do that once, and triglycerides. And if you have those three, you can really predict your risk of atherosclerosis.
Yep, you've passed lipids 101 if you understand that.
Mm-hmm. Can you just clarify one thing for me? Let's say someone does not have ApoB measured, but they have measured their LDL cholesterol. And you spoke about discordance before. And I think you mentioned one of your studies that looked at people, about 20% of people that had low LDL cholesterol had elevated ApoB, so there was discordance. Is there any clues in a standard lipid panel? Let's say you have an LDL cholesterol of 50 milligrams per deciliter, and someone is listening now going, okay, I don't have my ApoB measured, but would I be right in thinking that if their triglycerides are also looking pretty healthy, pretty normal, that would potentially be a clue that their ApoB is going to be concordant?
If you want to make a gross generalization, what you said is probably true. But that's a gross generalization which I would not want to bet your life upon. So let me explain discordance, why you can have a good LDL cholesterol and a high ApoB, or vice versa, terrible LDL cholesterol but a normal ApoB. The two things that determine your total LDL particle concentration are two distinct characteristics. Particle size, meaning particle diameter. LDLs are a heterogeneous group of lipoproteins. Some are rather small, some are rather big, some are sort of in between. It's like people. There's skinny people, there's normal belly-sized people, and there's those with the increased girth people. But they're all people. So you have LDL particles that are heterogeneous mix. So they differ by their waist circumference, their diameter. But how else might these people differ? By the composition of their particles. There's basically only two lipids in the core of an LDL particle. X amount of cholesterol ester, cholesterol, and X amount of triglycerides. Any other lipid that's in there would be such a minuscule component that we don't have to talk about it right now. So a physiologically normal, a normally composed LDL particle, typically, if you look at its core lipids, is 80% cholesterol and 20% triglycerides. But what happens if I have people who have a normal size LDL, but for whatever reason, they have way more triglycerides than they should have in their LDL? Maybe they have 50% triglycerides. If the LDL has excess triglycerides, what does it have less of? Cholesterol molecules, because the volume is fixed with that certain diameter. So you can, if you have extra trigs, you have less cholesterol. If you have extra cholesterol, you have fewer triglycerides. All right. Now, the diameter of the particle, though, has everything to do with the volume of a particle. For those who remember geometry, the volume of a circle, a sphere, is 4/3 pi radius. It's a third power of the radius. So even a half nanometer size difference in an LDL particle translates into several hundred more cholesterol molecules a particle can carry. So I'm going to send you a slide because it's much easier to look at this slide than me talking about it. I'm going to show you 4 LDL particles. Let's start on the left. It's a normal size LDL particle, not small, it's normal size. And it has 80% cholesterol and 20% triglycerides. How many cholesterol molecules would be in that LDL particle? This is all worked out. About 2,100 molecules of cholesterol would be in that LDL particle. Now, right next to it, second from the left, is the exact same size LDL particle, but it's 50-50. There's way more triglycerides in it than it should be. So even though the particle is identical, the particle on the left had 2,100 cholesterol molecules. This one has 1,800 cholesterol molecules. Now shift to the number 3 from the left. It's a small LDL particle, but it's got normal composition, 80% cholesterol, 20% triglyceride. It might have 1,500 molecules of cholesterol. It doesn't have the 2,100 because it's a smaller particle. And on the right is the most feared LDL of all. It's a triglyceride-enriched LDL. It would have very few cholesterol molecules, maybe 1,200. So you have 4 different LDL particles, too big, too small. What determines your LDL particle counts? If you have a mass of, say, 120 milligrams of cholesterol, it takes a hell of a lot more cholesterol-depleted particles than cholesterol-enriched particles to traffic the amount of cholesterol in your system. So people with the highest ApoB, the highest LDL particle counts, have small LDL particles, or they have big LDL particles that are triglyceride-enriched. So obviously what you hinted at are the triglycerides part of the story here. Yes, they are. But here's the problem. You could make a generalization that, yes, as your trigs goes up, you're going to have cholesterol-depleted LDL particles. But there's no triglyceride level I can ping. Aha! Your trig is 150. You are full of small or triglyceride-rich LDL. Maybe, maybe not. I have never had a triglyceride level above 105 in my life. I've been extremely insulin resistant, and yet I've had all those cholesterol-depleted particles. But yet, and I was a doctor. Oh, I never have to worry. My trigs are 102 today. I was drowning in triglyceride-rich lipoproteins that just could not be diagnosed by looking at a triglyceride level. So I think that's why you need an ApoB. Had I done an ApoB early in my life, I would have seen, good God, what is the cause of your high ApoB? Back then, I wouldn't have known that I had cholesterol-depleted LDL particles. And I'll wrap this up by saying, now I'm going to explain why diabetics typically have low HDL cholesterol. Because an HDL particle should carry virtually no molecules of triglyceride, a couple. But as triglycerides go up in the bloodstream, and they're mostly carried in VLDLs, the VLDLs transfers their triglycerides to the HDLs. The HDL ships its cholesterol back to the VLDL in a one-on-one swap. So all of a sudden you develop triglyceride-rich HDLs, a very pathological particle. But if the HDL is gathering triglycerides, it's losing cholesterol. If the group of HDLs loses cholesterol, their HDL cholesterol will drop. But where is it going? Into an ApoB particle. That's why you have to measure ApoB in low HDL cholesterol. And this is a reason people use this triglyceride HDL cholesterol reason. And they say, hey, if it's abnormal, you're going to have high ApoB, small LDL particles, VLDL remnants. They don't say that, but that's what's really going on. They think it's some marker of whatever. It's kind of, if you believe everything I've said about HDL cholesterol, it's the world's most useless marker. HDL cholesterol correlates with nothing. What we really need to know about HDLs is, do your HDLs perform the proper functions that are cardioprotective or whatever else they do? Or might you have the type of HDLs that are injurious to your artery walls? They're called dysfunctional HDLs. The only blood test I know available to evaluate HDLs is HDL cholesterol. And HDL functionality has Zippo relationship to HDL cholesterol. So you just don't know. So therefore, if HDL cholesterol is a useless metric, any ratio that imbibes HDL cholesterol is a useless ratio. There's all sorts of ethnic variabilities with that ratio too, which I don't have to get into. So it should not be used. Stop using the triglyceride HDL cholesterol ratio.
And just to clarify or tie off on one thing that you said there, because there is this kind of, I guess, rhetoric online that LDL cholesterol being elevated doesn't matter so much if the particles are large and fluffy versus this small, dense. But what I'm hearing from you is that really what determines the risk is the number of total particles, the ApoB, and we should probably be focusing less on whether the LDL particles are small, dense, or large, fluffy.
Yes, and the simple thing that shoots that down and murders that silly assumption is one of the two highest risk atherosclerotic diseases are familial hypercholesterolemia, whether you identify the genetic risk factor or whether it's polygenic hypercholesterolemia, where you can identify what gene is abnormal. They have about the highest risk you can have for heart disease. Those people virtually have 100% fluffy, buffy, large LDLs, but what do they have? A ton of them. So the big LDL crashes the artery wall. The rule is with entry into the artery wall, any ApoB particle that has a diameter less than 70 nanometers in diameter can enter the artery wall. Let me now rattle off the ApoB particles that have a lesser diameter than 70. Every chylomicron remnant, every VLDL remnant, every IDL particle, and every LDL particle. The biggest LDL is 25 nanometers. The smallest is 18. So there's no shortage of ApoB particles that can sneak through the artery wall. Maybe if you have a chylomicron that's 200 nanometers in diameter, that's not going in. But as soon as this loses its trigs, it becomes smaller and then it's going in. So it's a silly old concept that should have been buried a long time ago.
Okay, so I'm interested in what the kind of upper level of ApoB is that we'd like to see for this young person. What do we want to see their ApoB fall under? And I think we spoke about 80 milligrams or 85 milligrams per deciliter previously as a kind of threshold. But the ESC guidelines, and I'll show a table 10 on screen here for anyone watching on YouTube, put into the show notes for those that are listening. In these guidelines, they put forward different apolipoprotein B targets and then the corresponding non-HDL cholesterol and LDL cholesterol, depending on someone's risk. And they suggest to target an apolipoprotein B level of 80 milligrams per deciliter, which corresponds to 70 milligrams per deciliter for LDL cholesterol for people who are under 70 years old that are at high risk. Do you think that this should be the level that even low-risk people should target?
This is a great discussion. Look, the goal, if you want to treat somebody, your goal of therapy should be to prevent this chronic disease from ever developing. And our problem right now is all of those goals you just rattled off are based on 10-year risk assessments. So in other words, if I make your LDL, your ApoB here, in the next 10 years, are you going to get a heart attack? Well, unless you're 80 years old, very few people are going to have heart attacks in the next 10 years. But if we start rethinking about lifetime risk of atherosclerosis, then the levels that are going to induce an 8-year-old to a lifetime risk of atherosclerosis are going to be a lot lower than is this kid going to have a heart attack in the next 10 years. It would be same with a 30-year-old man or woman. At what ApoB or LDL cholesterol do I worry about so I can ensure them, hey, for the next 10 years, you're not going to have an event? And at what ApoB, LDL cholesterol, can I look at them in the eyes and say, for the rest of your life, you're never going to have an atherothrombotic event? So more and more in the paper you just cited today that came out, we're starting to reevaluate and look at lifetime risk assessment. And for the same reason I tell you to stop smoking when you're 12 years old. I don't wait. I'll smoke for 30, 40 years, and then I'll tell you to stop it because half your lungs will be destroyed and you might have cancer by then. So I don't want your arteries to ever develop. I don't want you to be one of those. I don't want you to be a soldier who has to fight a war, but I don't want you to get run over by a car and they find out you had coronary artery disease, or God forbid, you had a coronary event at a young age because you never got your lipids checked. So these artificial numbers that they come up with, what are you looking to do? Prevent a heart attack in 10 years or lifetime reduction of risk of heart attacks? And that will choose what you want. Now, interesting, if I like to look at it, first of all, what I'm going to tell you is going to tell you two things, that there's no such thing as a low ApoB can hurt you. So do you really care how much I lower your ApoB or cholesterol metric that correlates with ApoB? When children come out of mom's womb and they start crying, if we measured their, and remember, they just spent 9 months in the womb having the most explosive growth development, brain development that they will ever have, and they come out with LDL cholesterols of 20 and ApoBs of 30. And oh my God, because if I made an adult patient LDL cholesterol 20, they'd have a heart attack. They'd go on the internet and say, I'm going to die tomorrow. That's funny. It's not killing all these kids that are coming out of their moms of cholesterol deficiency. If we then take the 5-year-old, and let's repeat, the ApoB is 50 milligrams per deciliter. And that kid has gone through the tremendous growth spurt, the brain development of childhood. His brain probably stops growing when he's 5 years old, But the low cholesterol levels, the low ApoB did not stunt the kid's growth, did not stunt his adrenal function. We won't know about his gonads until he hits puberty, but trust me, it's not going to screw up his gonads by the time he can start using them. So we just have to stop fearing that these low metrics are dangerous in any possible way. These kids with such low ApoB and LDL are not dying of malnutrition or anything else. So ideally, then, as Peter Libby said in some of his poems, that's the physiologic ApoB concentration, 30 to 40. The physiologic LDL cholesterol level is 10 to 30. And if we could all, by some miracle, maintain LDL cholesterols of 10 to 30, ApoBs of 30 to 40, there can't possibly be atherosclerosis, LP(a) aside. How do we know that? By some of the genetic diseases that teach us that. And there's two I want to talk about. The first, I've mentioned the word PCSK9. PCSK9 is a protein that destroys your LDL receptors. LDL receptors is what pulls your ApoB particles out of plasma into the liver for catabolism. So you want to have a lot of LDL receptors. If you do, you'll never have a high ApoB. But PCSK9, once the LDL receptor comes into the liver, PCSK9 destroys it. So if your liver destroys your LDL receptors, you can't clear ApoB particles. Your ApoB level is through the stratosphere. People with genetic, it's called gain of function of PCSK9, they overproduce PCSK9, have no LDL receptors. It's one of the causes of familial hypercholesterolemia. They have significantly premature atherosclerotic disease. But there's another group who God liked, and he gave them loss of function of PCSK9. They can't make PCSK9. Their liver cannot destroy its LDL receptors. Their LDL receptors' half-life is extended. They clear LDL particles like there's no tomorrow. They go through life with LDL cholesterols of 10 to 20, ApoB levels of 30. There's virtually no evidence of atherosclerosis in these people, and better yet, there's no evidence of any cholesterol deficiency in these people. So, wow. The other genetic defect, not quite as potent, but it all moves in the same direction. We absorb cholesterol from our gut lumen into the intestine, which sends it into the liver. The receptor that pulls cholesterol from the gut lumen into the enterocyte is called the Niemann-Pick C1-like-1 receptor, NPC1L1. It grabs cholesterol molecules, it pulls them in. If you don't have NPC1L1, meaning you have genetic loss of function of the gene that controls, you can't absorb cholesterol in your gut. Those people have low LDL cholesterol, and they have a drastically lower incidence of atherosclerotic heart disease as time goes on. Now, their LDL cholesterol isn't as low as the loss of function of PCSK9. It's maybe 15 milligrams per deciliter lower than what the average person would have. But over a lifespan, simply having LDL cholesterol reduced by 15 milligrams per deciliter translates into no heart disease. So we have two genetic, and the cool thing is now, for us lipidologists who are into therapeutics, if you weren't born with the right genes, I have a PCSK9 inhibitor that will do exactly what the function of the gene does. If you don't have loss of function of Niemann-Pick, I've got a drug called ezetimibe, which takes out the Niemann-Pick C1-like protein and causes hypoabsorption of cholesterol. Both of those drugs have now been proven to reduce the incidence of atherosclerotic disease, make the arteries look better on imaging. So it's the genetic, if we knew the genetic stuff years ago, it would have been so easy to discover what drugs you have to invent. It came later.
So if we're looking at, and I appreciate what you're saying is lower the better, there's no real downside to...
And sooner the better. Those people, their LDL is low at birth.
Right. So sooner the better, lower the better. We see that from these genetic studies. And that goes back to what we were talking about earlier, the cholesterol years, thinking about lifetime exposure to these ApoB containing lipoproteins. So let's say early in life we measure someone, Tom, and their ApoB is 65 or 70 milligrams per deciliter. So it's kind of below that threshold, but it's not super, super low. It's not where they would have their ApoB level at birth. Is there, like, when would there be an indication for drug therapy? Like, what's that sort of threshold where you'd be thinking, okay, I'd actually like to get this ApoB lower?
Yeah. So what we do then is we look at our epidemiological studies, the clinical trial data, even some of the Mendelian data we have, and we see these are not these genetic freaks who've been blessed with the great genes, but we still have to sooner or later start respecting ApoB in them. At what level? So what we do now is we use what we call population percentile cut points. So if I took everybody in the world and measured, let's say, ApoB on them, you're going to have some people who have really, really low ApoB. Some of them will be genetic. Some will be whatever, probably genes we haven't discovered yet. And then there will be the nightmares on the right side of the bar where, oh my, their ApoB is in the stratosphere. And then it's a bell-shaped curve. There will be some people right in the middle. So who do we worry at? So with ApoB, below 60 would be, you're in the bottom 5th percentile of the human population. Not many people with ApoB below 60 ever get heart attacks, and especially the longer it's been under 60. I mean, if your ApoB's been 200 and next month I make it 60, you've still had 50 years of exposure to ApoB, but you get the point. And likewise, if I start to see, wow, your ApoB is like above 120, that's the 80th percentile. That's the heart attack zone. So if you came up to, even a young person came to me and their ApoB was in the 80th percentile, I'd have to talk seriously to them, or if they are still adolescents, to their parents, and convince them that now is the time we're going to start trying to do what we can do pharmacologically. If you see there are lifestyle issues, you will certainly educate him on all of those things too, all crucial, important. You'd watch their blood pressure. You obviously wouldn't let them smoke. But that's, I think, at an 80th percentile ApoB, pretty much adolescence and above, you have to start considering treatment nowadays, because it's this ApoB years that we're really worried about. So how about now what's the 20th percentile? And that would be with an ApoB of around 80 milligrams per deciliter. So most physicians nowadays, if you didn't have 6 other cardiovascular risk factors, you're not a diabetic, your mom, dad, and Uncle Joe didn't croak when they were 22 years old of a heart attack, so you have less, they're not hypertensive little kids or young adults, you would probably be happy with an ApoB of 80. It starts to hit around 100. You come to me, a lipidologist who believes this sort of LDL years, you're my son, you're going on a drug with an ApoB of 100. Look, if you've got the worst lifestyle in the world, you would always try that for X number of months and see what you can do. So those are sort of the numbers. I think if you had an ApoB of 100, 120, and you're in this so-called early primary prevention phase, we would try and make it 80. I don't know that I would try and blow it down to 40. I could with today's drugs, but that might be overkill. But I'd watch you closely, and at a certain age, imaging is not good early in life. You can start doing it later in life to see, my God, is there plaque that we didn't realize? Some people use the carotid imaging, which is non-invasive and very easy to do, and certainly carotid irregularities would show up before a coronary calcium test turned positive. So there are other ways of more seriously investigating a patient. So there's no set rules. Everything is, you do a really super family history, you examine the patient, and you also get a feel, if you're a good doctor, this person could be ready to die next week and they would never take a drug even if you suggested it to them. So, you have to be careful. You can't come out, not talk to anybody and say, here's 2 prescriptions, start them tomorrow.
Let's say someone presents to you who's consuming a diet that contains a lot of dietary cholesterol. So this kind of feeds back to something we were speaking about last episode, and I guess trying to determine if someone is a hyperabsorber. So they have an elevated ApoB. They tell you that, as part of their diet, they're doing 6 or 10 eggs a day kind of thing. Maybe it's 1,000 or 1,800 milligrams of dietary cholesterol a day. Would you be interested in trying to determine if they are one of the 20% of people that are a cholesterol hyperabsorber, and how would you kind of go about doing that?
Now, let me tell the audience, I've written 2 over 30-page textbook chapters on understanding absorption of cholesterol in the gut. So it's a particular major league interest of mine. And it's super complex. So the bottom line would come down to, look, if you had a normal ApoB, I don't care whether you're a hyperabsorber or a hypersynthesizer, ApoB is the determinant. But if you did have a high ApoB, would it be nice to know, is that due to your body is making too much cholesterol or is absorbing too much cholesterol, or both? And the answer would be yes, because if your ApoB, once it's at a certain threshold, I'm going to recommend a drug for you. So if I could prove you're just the hypersynthesizer, then you want a drug that inhibits cholesterol synthesis. And we have 2 nowadays, statins and bempedoic acid. If I see, boy, your ApoB is all that, your gut is out of whack and you're overabsorbing cholesterol like there's no tomorrow, but you're not oversynthesizing, I would give you a cholesterol absorption blocker, the ezetimibe. It's sold as Zeti in the United States. It has different brand names in other countries. If I did some sort of testing that showed, my God, this person is just synthesizing too much cholesterol and absorbing it, I would use combination therapy to get your ApoB under control. By the way, here's how those drugs lower ApoB. What determines your clearance of ApoB particles out of plasma is, I hinted at it, how many LDL receptors your liver makes. That's a protein that the liver makes. It's like a claw. It goes to the surface of your liver, it reaches into the plasma and grabs anything with ApoB on it and pulls those particles into the liver and they get catabolized. Obviously, if you're clearing ApoB particles, you will reduce the ApoB level in the blood. So what determines whether a liver makes or doesn't make LDL receptors? You want it to make a lot. It's how much cholesterol is in the liver. If you have too much cholesterol in your liver, either because your liver oversynthesizes it or your gut overabsorbs it and sends it to the liver, you now have a cholesterol-rich liver. Too much cholesterol is toxic to any cell. It crystallizes. Too much cholesterol is a cause of fatty liver. You don't want fatty liver. It can destroy your liver over time. If your liver is full of cholesterol, the first thing it does in defense is saying, good God, stop making LDL receptors and stop pulling LDL particles carrying cholesterol into the liver. That's like adding fuel to the fire. So your liver doesn't express LDL receptors anymore. So how can I get your liver to make more LDL receptors? I have to deplete the hepatic cholesterol pool. Stop synthesis. Statin, bempedoic acid. Stop absorption, ezetimibe. Both or either one of those would deplete a source of cholesterol for the liver. The liver does need cholesterol. It would start expressing more LDL receptors and clearing your ApoB particles. So with that rationale in mind, let me tell you how to diagnose hyperabsorption or hypersynthesis. And let's start with synthesis because that's the easiest. Remember, every cell in your body produces cholesterol, no exception to the rule. And all cells make an eensy-weensy tiny bit of cholesterol that they need to put in their cell membranes for normal cell membrane function. Most cells do nothing else with cholesterol except steroidogenic tissues, adrenal cortex, and gonads make reproductive or adrenocortical hormones. So they actually produce a little more cholesterol than other cells because they need more. So no cell is overproducing cholesterol under normal circumstances. All right. So how would I know whether the cells in your body are producing cholesterol or not? I'd have to understand the cholesterol synthetic chain. It's a 36, 37 step product A to product B to product C to product D, and product 37 is cholesterol. So there's numerous intermediate steps. It starts with either citrate or acetate. One is a ketone body. So, if you're going to go on a ketotic diet, you might have a lot of substrate to produce cholesterol. So that's an afterthought for perhaps a future discussion. So through many, many steps, when you get to step 36, and when you get to like around step 20, there's a bifurcation in the synthesis pathways. You go down two separate chains, but at the end of the road, the chains may merge and they turn into cholesterol. The one chain was discovered by a guy called Conrad Bloch. It's called the Bloch pathway. The others were discovered by scientists Kandutch and Russell. It's the Kandutch-Russell pathway. So all you need to know is what is the sterol number 36 in each chain that through one more intervention becomes cholesterol. They would be called the penultimate sterol molecules because you putz with them, they're going to become cholesterol. Through the Bloch chain, it's a sterol called desmosterol, D-E-S-M-O-S-T-E-R-O. Through the Kandutch-Russell pathway, it's lathosterol, L-A-T-H-O-S-T-E-R-O-L. Bingo, and they both turn into cholesterol. So if I would like to know, is Simon's body overproducing too much cholesterol? I would measure both desmosterol and lathosterol. I don't know which pathway is predominant in you. Most people have both. But if either desmosterol or lathosterol or both are elevated, I know you're an overproducer of cholesterol. I can't just measure cholesterol because you could be overabsorbing it and have nothing to do with synthesis. So measurements of desmosterol or lathosterol, if elevated, suggest you're a hypersynthesizer, and you would likely be a super responder to a statin or bempedoic acid if your ApoB was high. Now, if you're an oversynthesizer and your ApoB isn't high, who cares? I'm not going to give you an ApoB lowering drug just based on you. But most of the people with hypersynthesis will have some degree of elevation of ApoB. Because remember, when you're over-synthesizing cholesterol in your liver will make less LDL receptors. If we inhibit cholesterol synthesis, your liver will start expressing LDL and you clear the ApoB particles. All right, so that's synthesis. That's easy. Those tests are available in specialized laboratories. Now let's get to the tough story, my 35-page chapter on absorption. Now, by absorption, we mean cholesterol molecules in your gut have to enter the enterocyte, which is the intestinal cell lining the gut lumen, and the enterocyte has to do something to the cholesterol and then put it inside a chylomicron, which is the ApoB lipoprotein the intestine makes, and then ship that lipoprotein out with the cholesterol, and it has a circuitous route, but it'll get to the liver and deliver absorbed cholesterol to the liver, and then the liver can deal with it. All right, so what are the absorption steps? The first question is, everybody has what is called an absorbable pool of cholesterol in their gut lumen. So I always like to joke, if I was like a little mini skin diver and I could take like a submarine down into your small intestine and I could start interviewing cholesterol molecules and, hey, Mr. Cholesterol, hey, Miss Cholesterol, where the hell did you come from? How did you get into this person's small intestine? One might say, he ate me and I somehow wound up in his small intestine. He swallowed me. His mouth started it. And the next one, it would actually be about the next 10 ones I interviewed would say, you know, I was made in one of the organs in the body and a lipoprotein brought me back to the liver and the liver just shot me into the bile, which emptied into the intestine and here the hell I am. So one of the cholesterol molecules would be of exogenous origin, ingest it, and the other would be of endogenous origin, synthesized in the body, got back to the liver's trying to get rid of it by sending it to the gut on the hopes that it'll be excreted in the stool, but all it did was become part of the now absorbable pool of cholesterol. So about 80% of the cholesterol molecules that are in our small intestine right now ready for absorption came from endogenous sources, came through the liver, the bile, and there they are. The rest were ingested. And that's why it's very, very difficult to overeat cholesterol. You just can't overwhelm the pool of absorbable cholesterol by eating it because your liver is dumping way more cholesterol into that batch. So some will get in, some will not. All right, so now you're in the intestine. A little caveat, almost all of the cholesterol you ingest are in the cholesterol storage form. It's called cholesterol ester. It's a cholesterol molecule with a fatty acid attached to it, much too big to be absorbed. But your pancreas will shoot out lipases, which deesterify the cholesterol into what's called free unesterified cholesterol. All of the cholesterol that your liver puts in the bile is free cholesterol. So you have to have free cholesterol. If you don't deesterify ingested cholesterol, and you'd have to have a pretty serious pancreatic disorder for that to happen, you can't absorb cholesterol, ingested cholesterol. So, all right, now the cholesterol molecules that are free and floating around, hey, you've eaten some triglycerides, they get hydrolyzed into fatty acids. There are some phospholipids that mostly came out of your bile, but they're there too. And do they just swim over to the villi in the small intestine and say, I'm here, absorb me? No. They are transported to the microvilli of the small intestine for absorption in little lipid transportation vehicles that are in our intestine. And they're called biliary micelles. And that is why your liver makes bile acids and dumps them in the bile, and they come out in the gut. And the bile acids round up lipids, free cholesterol, hydrolyzed fatty acids, phospholipids, and all of a sudden you've got, it's like a lipoprotein, but there are no proteins on it. The bile salts are surrounding the lipids. And those little micelles, these spheres of lipids, they invade the microvilli of the small intestine. And that's where various lipid absorption transporters come into play. I've already introduced the Niemann-Pick C1 light transporter. That will recognize any sterols that are in your biliary micelles, which might be the free cholesterol, but maybe you ate a bunch of plants and veggies today, so you ingested phytosterols, which are different type sterols than our cholesterol. They're structurally different, but they're similar enough that the Niemann-Pick will absorb both phytosterols and cholesterol. They're in. Fatty acids get absorbed by a totally different receptor. It's called the CD36. So fatty acid absorption has nothing to do with sterol absorption. So many people confuse. They think there's just one absorptive mechanism for everything, and there's not. All right, so let's forget about the fatty acids for now. Cholesterol and some phytosterols got in. Typically, Niemann-Pick has a stronger affinity for cholesterol than it does phytosterols, but it ain't that bright, so they both get in. Humans have no use for phytosterols. We're not plants. Humans can't synthesize phytosterols. They cannot be used in the body. Above a certain level, they're actually dangerous in the body. So the intestine has a secondary job. Once Niemann-Pick has pulled it in, the analogy is Niemann-Pick is like the bouncer at a nightclub that you're going to. He's supposed to weed out the undesirables, but there's always a few creeps who get past the first bouncer. But now you're in the actual room, you're in the enterocyte, there's a second bouncer, and it's called an ABC G5 and G8 transporter. It's a sterol efflux transporter. If the Niemann-Pick let in too many damn sterols of any type, the ABC G5 or G8 grabs them and says, oh no, they kick them right out the door. They efflux them back to the gut lumen. So it's the backup bouncer. So if you're a sterol, to really get into the enterocyte before you get into a chylomicron, you got one pulling you in, but you got a sensor evicting you if too many came in. If humans have perfect Niemann-Pick function and ABC G5, G8 function, they will have normal absorption of cholesterol because they work hand in hand to maintain intestinal cholesterol homeostasis. All right, so now you have free cholesterol. Maybe there's still a few phytosterols left over. That ABC G5, G8 really hates phytosterols, and he throws them out first before he does cholesterol. So there shouldn't be any left, but you know, not everybody has the most perfect ABC G5, G8 transporter either. What's the next step? Before it can ever get into a chylomicron, it has to be changed from free cholesterol to cholesterol ester. So we need an enzyme to esterify it. Acyl cholesterol acyltransferase, ACAT. So that enzyme has a much higher affinity for cholesterol than phytosterols. So it will esterify a large amount of cholesterol ester. Perfect. That's a very hydrophobic cholesterol. It goes right into the core of the chylomicron. It's joined with triglycerides. You wrap them with phospholipids and some free cholesterol. You wrap them externally with ApoB48. Bingo, you've got the chylomicron. It goes into the lymphatics, up, out the thoracic duct, systemic circulation, drop off the trigs at the muscle, and then bring the cholesterol to the liver. If there's any phytosterols in the chylomicron, they got into the liver also. And the liver has an ABC G5, G8. It'll evict them quickly back into the bile. There's one other way cholesterol gets in. If there's cholesterol in the enterocyte, it doesn't all have to go in a chylomicron. That enterocyte can express another sterol efflux transporter called ATP binding cassette transporter A1. That effluxes free cholesterol from the enterocyte into little baby HDL particles in the plasma. So some of the cholesterol that's in your HDL particles came out of the gut. A poor man's signal of hyperabsorption of cholesterol is your HDL cholesterol tends to be on the high side. So look, there's a lot of exceptions to this rule. I've always told clinicians, if you see both high LDL cholesterol and high HDL cholesterol, you should at least be thinking of overabsorption of cholesterol. And if you're not doing the fancy tests, a trial of ezetimibe might be indicated to lower the LDL cholesterol, or it's the associated ApoB. It's just a poor man's marker of hyperabsorption of cholesterol. But what are the real tests? I've taught you desmosterol and latosterol for synthesis. So what sterol should never be in your bloodstream? Phytosterols. You're not a plant. You can't synthesize phytosterols. If you have phytosterols floating in your plasma lipoproteins, you have absorbed them. And if you are absorbing phytosterols, those receptors in your intestine are broken because they are geared to never absorb phytosterols. So we look at phytosterol concentrations in the blood, and again, beyond a certain threshold, they are strong indicators that you're a hyperabsorber of cholesterol. And so we measure then the phytosterols that are most common, and there are over 30 to 35 phytosterols, but the two that are usually measured are sitosterol, sitosterol, and campesterol, campesterol. So I look at those. The labs that are doing them include a panel that gives you the phytosterols for absorption, and they give you those two penultimate synthetic sterols. And by looking at the two, you have a good handle on hyperabsorption, hypersynthesis, or both. And that, if you have to lower ApoB, instead of guessing what drug to go on first, hey, it's synthesizer. A statin should work very well. Those are the people who hyper-respond to statins. If you're not a synthesizer, you would probably have a hypo-response to a statin. Vice versa, if you're a hyper-absorber, you get an exaggerated response to ezetimibe. If you're a hypo-absorber, you get a hypo-response to ezetimibe. So they're very good markers to know ahead of time. And look, if you see you got both defects, a low-dose statin plus ezetimibe, even intermittent ezetimibe, might be your best way of conquering ApoB in that patient. So, folks, the good news is these two tests are now available direct to consumer at least in the United States, probably not in other countries. So you contact this company, they're right online. I think it's called Empowered DX. I'll send you the link, Simon. They send you a little card, you prick your finger, you get 1 drop of blood, you put it on there, you mail it back to them. The cost is $99, but you get those 4 very valuable sterol markers, and it can help you make a therapeutic decision.
Yeah, I think that's the best explanation I've ever heard. Can you just remind everyone from a primary prevention point of view and a secondary prevention point of view, what are the kind of ballpark ApoB levels we want to see?
First of all, measure Lp(a) so you can dismiss that or worry about it. Get that out the way. One-time test. Then you get your lipid panel. You look at 3 things. Is my triglyceride above 500? Then you have a genetic triglyceride issue. Seek out a lipidologist for care for that. Most run-of-the-mill doctors can't handle that properly. All right, but your trigs is not over 500. So, if it's between 150 and 500, you ought to worry about it a little bit. But the 2 things that determine your future and your cardiovascular outcomes, if you're not getting ApoB, is your LDL cholesterol level, but better yet would be that non-HDL cholesterol level. And remind your viewers that is a simple equation. You take total cholesterol, you subtract from it HDL cholesterol. That is the cholesterol that is not in your HDLs. It's your ApoB cholesterol. If ApoB cholesterol is up, the odds are good your ApoB is up. So those are the poor men's ApoB. And if you happen to see low HDL cholesterol, whether the triglycerides are up or not, just assume you have high ApoB. And look, if your HDL cholesterol is low, your non-HDL cholesterol is going to be high because you're subtracting a smaller number from your total cholesterol. So it all fits in. And so that's step 1 in getting risk. And if you have serious perturbations of that, you should talk to your doctor. If any lipid concentrations are abnormal and your doctor tells you not to worry about it, find another doctor ASAP. If you have serious abnormalities at any of those lipids that I just mentioned, go to the American Board of Clinical Lipidology and find a lipidologist in your area, a person trained to truly understand lipids and manage lipids. It's the number 1 cause of death. Don't ignore lipid concentrations. Don't ignore subtle hypertension. Do not smoke. Those are the 3 ways to eliminate vascular disease, strokes, heart attacks, and all the other junk that follows them that you never want to have. so preventable. And we have so many safe and easy to use drugs. We don't even have these old drugs that had more side effects than the modern drugs are so safe, so easy to use. But don't run quickly if the doctor tells you you're young, don't worry about your lipids, or you're a woman, don't worry about your lipids, only men get heart attacks. Rush ASAP out of that office.
Bill, what is the kind of current model or lipid hypothesis as it stands today?
Well, I take you back. So the history of how we got here, I think, is important to answer that question. So the history of how we got here was, it was not lost on people that cholesterol was in plaques back in the late 1800s, early 1900s. Now, how it got there was a mystery. Was it made? Was it transported? It didn't appear to be made, so it had to be transported. And now you have to ask more questions. How do you move cholesterol, which is a fat, in blood, which is mostly water? And people thought, well, maybe it hitches a ride with albumin or a plasma protein, that sort of thing. But the real work here came from two guys, Goffman and Lindgren, in the 1948 to 52 time span. And they characterized human lipoproteins. They're the guys who figured out that we have these particles. They look like tennis balls. They're hollow on the inside. And inside, which is a fat safe place, the cholesterol and triglyceride get packed in the middle. And these particles are the way that we move cholesterol around. And so that was the beginning of what some people call the cholesterol hypothesis. It was really, how did cholesterol get into plaque? And then what did we learn about the particles that carry cholesterol? So in my world, I'm a little careful in the way that I discuss this, because I don't think it is a lipid hypothesis. I think it is a lipoprotein conversation. Lipoproteins are the core of this conversation. And this was actually what they thought would be the conversation beginning in the 50s. But it's hard to measure lipoproteins, especially back then. But you can measure cholesterol much more easily. So what you can measure easily becomes a surrogate for the rest of the story. Interestingly, some pioneers that were giants of the day in the 60s at NIH, Friedrichsen, Levy, and Lees, talked about the facts that, and they lamented this. They said it's unfortunate that people are talking about lipoproteins as a cholesterol problem. Really, that's not the case.
Cholesterol is just kind of getting caught up in this.
Cholesterol is a neutral fat that's stuck inside a particle. The cholesterol in HDL is the same as the cholesterol in LDL. Right, one is not good, one is not bad. One does not protect you, one does not hurt you. It's the particles that have the potential for good or for bad. And so what we think the model is today is, if you have any number of problems or processes that give you lots of ApoB containing lipoproteins, and that stays high for a long period of time, that is part of the process that fuels formation of plaque in the artery wall that can grow over time and under various circumstances lead to heart attacks and strokes.
Is that independent of other factors? You know, one of the things that I was speaking to Tom Dayspring about when he was on my show was whether those lipoproteins, I think you said there, they have the potential to be good or bad. Are they inherently problematic, or is a particular environment or concentration required?
Yes and yes. So ApoB containing lipoproteins, specifically LDL and remnants, are very atherogenic. There are lots of models where we can show that persistently high levels of these are directly related to development of plaque, independent of anything else. But like anything else in the body, multiple contributors together have a different impact than just one. So if you're a smoker, hypertensive, diabetic, if there are other things going on that also set the table for atherosclerotic risk, and you add a high ApoB to that, that's a very different environment than just high ApoB.
Right.
So yes, you can amplify the deleterious effects of ApoB by other things, but it is not true that you have to have other things for ApoB to be deleterious.
Okay, so you can be otherwise completely healthy, but have an elevated ApoB above some physiologic level, and at that point, those lipoproteins will be problematic.
So this is a concentration conversation. The higher, the longer, the worse. So there's not a step function or a threshold above which people are in dire straits, but it is a continuum of risk. And as you escalate the number of particles to extremely high levels and you leave them there for an extremely long period of time, that would be one working example where you can say, yes, under those circumstances, absent some other thing we don't understand, such as favorable genetics or other factors, this is a setup for plaque formation and increased atherosclerotic risk.
So do you think that applies, and we'll unpack the triad, the lean mass hyperresponder, but do you think that applies in this context of what's, Dave's experience himself, where otherwise, metabolically healthy, I'm assuming, triglycerides, high HDL, perfect, but his LDL is high above that physiologic level?
I think it's a great question. And you just teed up a different conversation. And that is that we're not a system that has only one thing going on at a time. So high ApoB usually exists in the context of other things. In this culture, high ApoB is usually part and parcel of insulin resistance, part and parcel of metabolic syndrome, part and parcel of prediabetes, diabetes. And so we have these other physiologic perturbances that are part of the fabric of atherosclerosis in which ApoB is layered. And so that's the most common expression of high ApoB-related risk that we have. Another example is familial hypercholesterolemia or other genetic disorders where you just can't clear your particles well. You don't have these other processes necessarily, but you do, unfortunately, have a lifelong exposure to very high LDL, very high ApoB, and there's a consequence to that. So we have these two different models, one which is physiologically unhealthy, the other which is genetically driven. And in both cases, high ApoB is contributory to atherosclerosis. But the magnitude and how much risk the individual has is more than just their ApoB level. It is a combination of all these other factors. And so one of the challenges clinically, when I see somebody, if you were my patient, I would seek to understand, Simon, what's the rest of your story? Are you insulin sensitive? Are you insulin resistant? Are you a smoker? Are you hypertensive? Are you diabetic? What other comorbid conditions do you have? What other things are important? And the guidelines are now beginning to reflect this as well. The guidelines has a whole list of things called risk-enhancing factors that you're supposed to ask about that contribute to potentially what your risk would be. And then we layer on top of that things like ApoB, Lp(a), lipoproteins that are atherogenic.
Right. And so you would find out all of that information because it may affect how aggressive you are or proactive you are with lowering my LDL cholesterol or ApoB, or how worried you would be.
Yeah, I think the question you would have is, if my ApoB is a bad number, what's the rest of the story? Now, we live in an age where we can do non-invasive imaging and we can get an answer as to, using certain modalities, do we see evidence of plaque already? If I see that you have plaque and you want to talk to me about your ApoB, that's a different conversation than somebody who is apparently physiologically healthy, has no evidence of plaque, has a high ApoB. And my question is, has it been that way for a long time? Is that a more recent phenomenon? These are important considerations. And we can kind of unpack this as we go, but there are combinations and permutations of this where in one extreme, let's say you're 75 years old with a 0 calcium score and a high LDL. The guidelines would say statins are optional for those people. At a younger age, you tell me that you have plaque and you have a high ApoB or LDL, I'm going to tell you that getting that down is the best solution at a lipoprotein level you have to stopping the growth of plaque, regressing plaque, decreasing LDL-related risk. And the term I just used there, LDL-related risk, I think is a very important nuance because it acknowledges, on the one hand, there is risk attributable to bad or atherogenic lipoproteins, but it's only one of many actors in the story of atherosclerosis. We have lots of data where people's LDL has been really well managed, and yet they can go on to continue to have events. So we just want to paint a broader context, a broader picture that, as important as it is, it's part of a bigger story.
I imagine some people might push back a little bit on that last part there, and they might say, well, Bill, you might still see events because you've intervened too late in life. And I know that there are certain people out there that, it seems to me at least, that there's this idea that the precautionary approach that, is ApoB the kind of, is it the spark that sets off the flame? And if so, if you just get it down to a low level early in life, are you going to help that person kind of avoid it? We don't know 5 years, 10 years out what this person's metabolic health is going to look like. Why not just aggressively lower it and get it to a safe level?
I agree with that. So primordial prevention is don't let it happen in the first place. Now, we have experiments of nature. You can look at people who genetically have low LDL for a lifetime, and they have markedly reduced atherosclerotic risk, irrespective of whether they smoke or they're hypertensive or other things happen in their life. Because if you kind of mechanistically look at this, you could ask, well, what's the committed step of atherosclerosis? And the committed step is forming macrophage foam cells. Formation of macrophage foam cells is the committed step of atherosclerosis. And what's a foam cell? A foam cell is a macrophage that ate atherogenic lipoproteins. So once you have begun that process, you have turned on the switch. All right, so that's an important caveat.
And just to underline something there, that process can begin if ApoB or LDL cholesterol is elevated without systemic inflammation,
correct,
without insulin resistance. It can sort of instigate that.
It can.
Some folks will be exposed to the term ApoB. And it seems like the conversation is starting to shift a little bit from LDL cholesterol to ApoB being potentially, at least in certain circumstances, a better predictor of cardiovascular disease or marker of kind of risk of atherosclerosis. Where does ApoB come into this conversation with regards to these different types of lipoproteins and why is it important? And this probably starts to take us down the path of the pathology and what's going wrong.
Yeah. Do you want to go?
Yeah. So this is kind of something that has refined our understanding over time. And so the best way to think of this is, as I just noted, for something like an LDL cholesterol or an LDL-C that someone might get measured, that is measuring the cholesterol content of that lipoprotein. But we can also care about how many of these lipoproteins we have. What is the number of particles? And so one way to try and assess the number of not only LDL, but other lipoproteins, apart from HDL, importantly, which I'll come back to, is by measuring this apolipoprotein B, or as we call it, ApoB, that sits on these lipoproteins. Now, importantly, this doesn't sit on the HDL particle, but it will be on the LDL, IDLs, VLDLs, these other lipoproteins that we consider to be more atherogenic than HDL. And I'm sure we'll explain that in a bit more detail in a while. And some of that relates to the density of that lipoprotein and therefore its size, and also this forward and reverse transport. But so we have a way to measure the number of those atherogenic lipoproteins, LDLs, IDLs, VLDLs, etc., that have this ApoB sitting on them. So there's one of these ApoBs on each of those particles. So by measuring ApoB, it's giving us a good idea of the number of these different particles. And that refinement in understanding risk over time has essentially highlighted that it's not necessarily the cholesterol content per se of those particles, but that is an important part, but the overall number of those particles, if we have much more ApoB containing lipoproteins, that elevates risk. There's a concept of concordance and discordance, which we can explore more, where in certain cases, if they're concordant, that means that pretty much an increased amount of ApoB or number of LDL containing particles, let's say, would be concordant or rise linearly with the increase in LDL cholesterol. In some cases, it can be discordant, which is where one may be a better predictor than the other.
So is that because in those circumstances, you have greater numbers of like VLDLs and IDLs, which also contain the ApoB, and less LDL?
It's interesting that there's a kind of as I understand that, kind of heterogeneity here in terms of that distribution, where you can have either an underestimation or overestimation of risk. So let's say you take someone that has an LDL cholesterol that would be in the normal range, that we would indicate as at low risk, but for whatever reason, their ApoB or even their LDL particle count is really high, so that would put them in the high risk count. In a situation like that, that person could be at higher risk than indicated by their LDL cholesterol result. But you also have, it seems on a distribution, people at the opposite end, that the LDL cholesterol might be look a bit higher relative to, they actually have maybe a lower ApoB count or a lower LDL particle count.
Is that because they have kind of more large, fluffy LDL particles that are carrying more cholesterol, but there's less of them? Is that how you'd end up in that position?
So it'd be essentially, as I understand it, as Alan said, this protein and cholesterol content that we have generally for these different classes of lipoproteins, but of course there's some variation, there's some kind of range within them of how much each of those particles may have. So if you, in a certain individual, have a greater cholesterol content per lipoprotein for that situation, that would lend itself to...
Okay. So bottom line though, the best predictor and the best way of kind of avoiding misinterpretation, if you're just looking at LDL, is to go directly to the number of particles and measure ApoB.
Yeah, I think ApoB is probably the strongest indicator relative to certainly an LDL cholesterol number. And that's twofold. One, you're actually getting the number of particles as opposed to the cholesterol content, but also you're accounting for other lipoproteins apart from LDL, which are also atherogenic.
Do you think most doctors sort of recognize that, and is that something that you think will start to make its way into routine blood tests?
So it is recognized. The various, the EAS have recognized the importance of a direct measure of ApoB generally. It's specifically recognized in the situations of discordance that Danny was talking about, which seems to affect about a quarter of the population, around 25%. So it's not an insubstantial number of people for whom only estimating LDL cholesterol might mischaracterize the nature of their risk. But there are calls now to just in everyone have a direct measure of ApoB as kind of the standard, but that's not going to necessarily be something that's happening overnight, because it's kind of cheaper and easier to measure. And LDL cholesterol isn't necessarily directly measured when you're in primary care. It's calculated from what's known as the Friedewald equation. So, yes, ApoB is more refined as a marker because it's capturing all of every atherogenic lipoprotein in circulation, irrespective of its actual subclass. But at the same time, there's additional, cost and kind of equipment and otherwise implications here. So yes, it's more ideal, but it's not necessarily going to be something that happens overnight. Although over time, I can imagine that there will be a push to shift screening towards direct measures of ApoB. It seems to be going in that direction.
What do you think about non-HDL as a marker? So because that shows up on most routine blood tests, that's pretty similar to ApoB.
So
right?
it's a good mark prior to the ApoB kind of era, so to speak. If we're in that now, non-HDL was as good a marker as you could get for capturing, again, all atherogenic lipoproteins in circulation that were not HDL. So as Danny said, HDL does not contain ApoB. HDL is reverse cholesterol transport. It expresses another apopolipoprotein. And so it's not involved in the processes. And also because of its size as well, hypothetically where HDL to get into the artery, it could actually kind of get out, basically. Okay. So non-HDL was providing a relatively, crude, but still, accurate enough for prediction estimate of all other lipoproteins in circulation that were not HDL. And that would have covered LDL. It would have covered VLDL. It would have covered, chylomicron remnants and these kind of particles. And if you look at some of the analyses that we're looking, obviously, in terms of predictive value for these kind of measurements, then, you know, non-HDL was a very, and it still is in certain contexts. You know, remember that this concept of discordance, while a quarter of the population is a lot of people, you know, in a majority of individuals, it is still sufficient to, you know, have an estimate of their LDL-C, and non-HDL-C can be, and concordance, if you're looking at, and was in one of our statements from Samia Mora's research, if you look at LDL cholesterol and non-HDL cholesterol, there's a lower proportion of people are discordant if you're looking at those metrics together than LDL-C and LDL particle count. Okay. So it's still a useful metric.
Yeah. And I mean, one additional thing to that is when we talk about even cases where there is discordance, that's still occurring within a certain range, right? Yes. So as some of the cases we may get onto later, where people have this incredibly high LDL cholesterol, like 300 plus milligrams per deciliter, you're not going to have a situation where someone's LDL cholesterol is that high, but like, oh, their ApoB is perfect. You know? So it's within a certain range the discordance happens, and it doesn't, at the extremes, it's just going to become irrelevant.
That's a good point. That's also good for folks to know if they speak with their physician and for whatever reason ApoB is expensive or they can't get it, that usually non-HDL is available. If someone's listening and they've been in that community, things are going well, lost some weight, enjoying the keto diet, ApoB's high, listening to what you guys have to say, they actually want to act on that, make some dietary modifications. What are they doing within the keto framework?
Yeah, so the simplest, so they're enjoying essentially a high fat diet. That doesn't necessarily have to be, of course, absent all carbohydrates. And there's two kind of modifications within that dietary pattern that would really be the most efficacious, that they would kind of almost have to do. One is, and the top line is modifying the composition of fat in their diet. So again, by all means, consume your 60 or 70% of your energy from fat, but that fat should primarily be unsaturated fats from plants and maybe marine sources. So I'm presuming, again, someone following a ketogenic diet probably is consuming animal sources. So we would say plant and marine sources for their unsaturated fat intake, and keeping their saturated fat intake to where we kind of generally recommend for population health. And that's not a threshold that's licked off the ground, and people in that community will love to denigrate the evidence, although they don't really seem to understand it at all. The reality is, it's not just epidemiology that our recommendations for saturated fat are based on. We have intervention trials, large-scale intervention trials that support that 10% threshold. That's where we see the biggest drop-off in cardiovascular events from dietary fat intake, from saturated fat intake. So there's no reason why they can't have a high-fat diet, but they should still be following those kind of general best practices for fat composition in their diet.
Right. And so that will naturally occur by eating less what and more of what?
Yeah, I mean, they'd want to be obviously probably selecting for kind of leaner sources of meat, maybe non-fat dairy sources, because they're going to be consuming a lot, I imagine, of animal produce generally. So maybe opting for kind of non-fat or low-fat, you know, kind of high-protein style yogurts, or opting for maybe more white meat compared to red meat, or even opting for fish over some of their red meat as well. So it's just overall reducing that, and not, you know, kind of having a pedestal on foods like coconut oil and treating it like a panacea. And then I think as well, secondarily, and this would obviously be through fat sources as well, would be really trying to also pay attention to their dietary fiber intake. And obviously they would be emphasizing different foods to someone following a slightly less restrictive diet, and, you know, avocado, chia seeds, flax seeds, these kind of foods to help actually maintain fiber adequacy. And both of those steps, I think, in terms of modifying fat composition and really paying attention to their sources of fiber that would suit a diet like that, to try and maintain fiber adequacy. And I think those two would be the most important steps they could take to try and help lower their cholesterol, factoring in that it may not necessarily come down to levels, that might be more optimal.
Right.
Yeah.
Which they would need to
Take a drug on top of.
Right.
Yeah.
Or change their diet
Or
to
just
something
stop.
that
Yeah, exactly.
has less total fat.
Yeah.
Well, I mean, one of the things that you see sometimes in that community is at least some of the people in that area are actually advocating for more saturated fat. And like, it's actually, you have to like purposely, like we were talking about earlier, unless you are eating a lot of ultra processed foods, you have to like purposely target high saturated fat foods to get to the level some of these people are consuming.
Yeah.
So purposely going for fatty cuts of meat and so on. So those changes, and to kind of echo what Alan said, are if you do want to go with a low carbohydrate, high fat intake, you can simply say, okay, for my meat intake, let me go for lower fat or cuts of meat that are leaner with less fat, and then not be doing things like purposely drinking down lots of butter and coconut oil to jack up your fat intake, thinking that this is helping your hormone production or whatever, and then relying on plant sources of fat is probably the easiest heuristic for people, right? Avocados, nuts, seeds,
Olive oil.
olive oil. Like you can get a good fat intake from those that are, and then by nature, those things tend to be part of healthy meals, right? So where are you going to get extra virgin olive oil? Where are you going to be adding it? Probably to a salad with lots of fibrous vegetables, which I think people forget can be part of a ketogenic diet.
Stuff,
You can get a lot of fibrous vegetables there. Putting some olive oil, throw walnuts on it, have it with a piece of salmon. Like there's a lot you can do where you can actually have a really healthy dietary pattern that ends up being high
Sort
in
of
fat.
a more of a kind of Mediterranean keto diet in many ways.
Right.
Yeah.
Yeah. And then you can eat within a framework that is very similar to a Mediterranean diet, which you have a ton of evidence for, and still have the benefit that for that individual that they get from being low in total carbohydrate.
Yeah. So it's probably from a standard Mediterranean diet, a little bit less whole grains or no whole grains and more non-starchy veg and a bit more fat.
Yeah.
Yeah. Okay.
Yeah.
Cool.
There's probably even foods like butternut squash, which because of their actual kind of both fiber to kind of usable net carbohydrate ratio could actually be included in a diet like that without kicking their total carbohydrate intake, over what kind of thresholds they'd be trying to maintain.
If you were going to maybe list, or whether it's top 5 or top 3 or just a few foods, so we're focusing on food here to make it simple for people, which are the foods that contain saturated fats which are going to have more of an effect on increasing our cardiovascular disease risk that we might want to be just a little bit more sort of cognizant of?
Butter, fatty meats, tropical oils, coconut oil, palm oil. Those would be the top offenders. Again, it doesn't mean that you need to eliminate them completely from your diet. It just means keeping them in a reasonable amount. And one other caveat is that with the tropical oils, I haven't seen outcome data. I don't know if it's out there. There is data on the effect on blood lipids. So there is, I would say the level of certainty there is I would put it a little lower than for the very fatty meats and the butter, pending outcome data. The suspicion right now would be that they would raise risk since they raise ApoB, they raise LDL cholesterol, but pending that confirmation.
Right. Okay. So that brings us back to your first P from our last episode of proof, and that not all evidence is equal. But I appreciate that disclaimer, and it sort of brings us into mechanism. So you're talking about blood lipids there. And I think people that have tuned into this show, and certainly people that have tuned into your show, will be well aware of this discussion around how saturated fat affects cholesterol and specifically ApoB, and how that can sort of modulate cardiovascular disease risk and increase the risk of atherosclerosis, this plaque buildup in our arteries. So is that the primary mechanism by which saturated fat is affecting cardiovascular disease? Is it the only mechanism? Are there other mechanisms that you're
aware of?
It's the one that has the most data behind it. So to give people a bit more detail, so I guess we could give people the 20-second primer, well, just in case people aren't familiar with ApoB or it's been a while since we heard about it. These fats, cholesterol, triglycerides, they are carried around in our blood. Fat and water don't mix. So the way our body solves that is by carrying fat inside these cargo ships, if you will, called lipoproteins. And lipoproteins have essentially two large families. One of those is atherogenic, raises risk of cardiovascular disease if those lipoproteins are very concentrated in the blood, in the plasma. And conveniently, that family carries a tag, a protein called apolipoprotein B, or ApoB for short. So we can measure ApoB and get a count of the number of those lipoproteins that are problematic. So that's ApoB. In terms of the mechanism of saturated fat, the most well accepted, the most documented mechanism has to do with the LDL receptor, which is essentially a docking station that exists in many places throughout our body, but the relevant location here would be the liver. And so these little antennae, these little docking stations are on the surface of the hepatocytes, the liver cells, and they bind to these lipoproteins, particularly the ApoB carrying family, and they internalize them, removing them from circulation and lowering the concentration of ApoB carrying lipoproteins in the blood, which lowers risk. When we up our intake of saturated fat, it removes some of those receptors on the surface of the liver, and the consequence is that less lipoproteins are removed from circulation, their half-life goes up, their residence time goes up, their concentration goes up, and risk goes up. So that's the most well-established mechanism. There are some others that are hypothesized, things around some inflammatory markers, coagulation factors, other proteins that are on the surface of lipoproteins that also determine their residence time and their binding affinity to different receptors. So there's research on that, but there's less certainty, I would say, than the LDL receptor mechanism.
There is no evidence that you can point to that would say this is definitively the single absolute best way for every human to eat for good health today and for good long-term health. But what is clear, and that often when people hear that, they think, well, does that mean we have no idea? No, we have a very good idea, but it's more of a theme or set of characteristics. And that theme, that time and time again has been shown to reduce risk of a lot of the chronic disease burden that is really robbing people of quality of life today: cardiovascular disease, type 2 diabetes, fatty liver disease, various types of cancers, Alzheimer's, dementia, etc. That theme that reduces the risk of all of those conditions is a diet that's low in saturated fat. It has a bias for unsaturated fats, particularly polyunsaturated fats. I think that's something we're probably going to talk about.
Definitely.
It's rich in fiber, and it's low in ultra-processed foods, right? And those are probably like the big kind of three things, as well as being low or hopefully excluding trans fats, which I think everyone agrees on today. Now, so that's very broad. What can that look like? It can be a very healthy, well thought out Mediterranean diet. It could be a pescatarian diet. It could be a vegetarian diet. It could be a very well-planned whole food plant-based diet. These are all different variations of that theme. In the literature, it's very clear that when you swap calories from saturated fat for polyunsaturated fat, we see an improvement in a number of important biomarkers. We see an improvement in LDL cholesterol, more specifically ApoB, if anyone's kind of familiar with that, essentially the same sort of thing, or telling us a similar information. And we also see an improvement in insulin sensitivity, so your body's ability to shuttle glucose into cells and use it. And in the context of someone who is eating excess calories, and a lot of people are eating excess calories. You can eat an ancestral diet and still be eating excess calories. In the context of eating above what your daily energy requirements are, if you're gaining weight on an ancestral diet with a lot of saturated fat, you can bet, and it will vary depending on your genetics, but you can bet it's not just subcutaneous fat under your skin on your face or your hips or wherever, it's going to be visceral fat. We know that saturated fat really drives up the fat in the liver and also in the pancreas. There's clinical trial after clinical trial showing that. Whereas when you swap those calories from saturated fat for polyunsaturated fats, you see a reduction in this very harmful ectopic fat, is what it's called scientifically, in the liver and in the pancreas. When you measure your ApoB or non-HDL, there's reference ranges. So go and get your test done.
Okay.
If you're high on those, then you might want to go back to your diet and understanding that the biggest lever that you can pull to reduce those is to swap calories from saturated fats for polyunsaturated fats, which in food form means less meats, less butter in particular, and less dairy fat if you're having a lot of it, and then more fatty fish if you eat seafood, or nuts, seeds, avocado, tofu, these kind of foods. That's what that would look like.
So why is it so important to reduce it?
So this comes back to the liver, and I said it's like the master regulator of metabolic health. One of the important functions of the liver is it has these receptors on it, these LDL receptors, and these receptors take up the ApoB particles, right? So that you can imagine that the issue with these ApoB containing lipoproteins in circulation is when they become too elevated, you get more of them crashing into the artery wall and getting retained. Like, it's part of normal physiology to have these. You know, I mentioned it's taking fats out to cells, so it's not a case of trying to get it to zero. But different fats have different effect on the LDL receptor. Saturated fats decrease the sensitivity of that receptor. So if you imagine that receptor is like a bit like a gate, okay, and it's allowing these ApoBs back into the liver out of circulation. So it helps lower the level of ApoB in circulation. That's one of the liver's jobs. When you eat a lot of saturated fat, you start to close that gate. They can't get back into the liver. So what happens? They're building up. Imagine you're back to the analogy of the cargo ship. Imagine you're looking at a port and the guys on the cranes have gone on strike. They're not clearing the containers. You have all of these cargo ships building up in that port, right? And now these cargo ships have, they're hanging around for longer. They can throw their anchor down and build up and get stuck. So saturated fats are reducing the receptor, the LDL receptor sensitivity. Polyunsaturated fats do the exact opposite. So polyunsaturated fats open the gate up. They help the liver clear these ApoB-containing lipoproteins. So that's the biggest lever that someone can pull, and that's very clear. There's metabolic ward clinical studies where they lock people up and feed them saturated fats and polyunsaturated fats and measure all of this stuff. In fact, there's a meta-analysis of 395 experiments, Clark, and I can put that into the show notes, that tested this exactly. So again, you can't really change or intentionally change something if you don't measure it. And so back to your question about like, how does someone know, and is there a difference between these different types of diets? It really comes back to the type of saturated fats they're eating, what foods are they in, and also their genetics. So that ability for saturated fat to shut the gate and polyunsaturated fats to open it is also modulated by our genes. So for example, I might be able to get away with a little bit more saturated fat than you, and that could be a genetic thing, right? So
but it's not going to be such drastic differences.
It's not going to be drastic,
yeah.
Huge differences, but it is important to acknowledge that, when we look at studies, you get the typical response, the average response. None of us are exactly representative of average. So you have to take the information and then, the broad theme, and then individualize it and personalize it based on your lab results, based on how you're feeling. And this is one of those examples where you look at an important risk factor, and then you can make a decision if you want to try and change certain aspects of your diet. There you have it, friends. I hope you enjoyed this episode. If you did and want to stay up to date with future episodes, be sure to hit that subscribe button on YouTube and follow on Apple or Spotify. Finally, thank you for showing up and the effort that you're making to take control of your health. I look forward to hanging out with you again in the next episode.